and National Oncology Institute in Slovakia. National Cancer Plan and Council recommendation already mentioned before is something what is waiting for implementation at the national level. So we would like to join to the future joint action led by future coordinator, University of Latvia, with the title of the project Implementation of Cancer Screening Programs. The focus will be on capacity building, monitoring, implementation of new screening approach presented by Council recommendation from the December last year, and improvement of our existing screening programs. Cancer control needs something more and shift from the paradigm which could be sometimes limited to healthcare provision only to be a broader multi-sectorial framework when we are talking about cancer control, to better reflect health as a result, as a public priority, addresses all determinants of health, not only healthcare, and focuses on health as an investment rather than cost, and has an overall impact on the social and economical development in Slovakia. There is a huge opportunity for all of us in this room for further synergies to close the gap between research, policy and practice. Strong governance on cancer control is still missing in Slovakia, and there is no implementation without the strong governance. So we really believe that prevention and cancer control will remain a priority for Slovakia and for the future update of our action plans, and those action plans will be continuously implemented and supported with the aim to improve the health status of the Slovak citizens. Thank you.
Thank you very much. And now Torsten Blum, co-chair of the Prevention, Early Detection and Screening Network of European Cancer Organization.
Dear ladies and gentlemen, dear colleagues, first of all, thank you very much to Onko Alianza Slovensko, I hope I pronounced it correctly, and the Ministry of Health of the Slovak Republic for inviting me, for hosting this event, and also thank you very much to all of you for showing your interest, for being here, and hopefully for promoting better quality in lung cancer care, not only in the Slovak Republic, but all over Europe. My name is Torsten Blum. I'm from Berlin. I'm a pulmonologist by nature, very dedicated to thoracic oncology, and currently my main field is implementing lung cancer screening. The Europe's Beating Cancer Plan is, I think, clearly a powerful tool for all of us within the EU to promote better cancer care throughout Europe, but especially in our individual countries. And two topics are in the EU Beating Cancer Plan on prevention, and also on early detection, namely screening of cancer. In my talk, I will mainly focus on lung cancer screening. We are well ahead of time, so please, after that, let's discuss about initiatives on prevention, because they are, of course, very worthwhile. It's always better to have primary prevention before individuals are exposed to risk of developing cancer. But please, let's not forget about those individuals who have already been exposed, like smokers, which is an addictive disease, because they are now at risk of cancer, and I think they also deserve that their potential cancers are detected as early as possible. I think we are all aware of the cancer screening process within the EU, which led finally to the recommendation by the EU Council, the update of the EU cancer screening recommendations last December. Before that, it was a long political process. First, there was the EU BICA group report approved by the European Parliament. Then, very important, SAPIR, the scientific advice mechanism within the EU, came up with their sophisticated evidence-based report for the 6 cancer screening types recommended in the new recommendations by the European Commission. And that's a solid evidence basis for all the 6 cancer types. The 3 existing ones, breast cancer screening, colorectal screening, cervical screening, but also the 3 new ones, gastric cancer screening, prostate cancer screening, and lung cancer screening, which I like to focus on. In addition, it's not only recommendations, but the EU is very keen that those cancer screening programs are successfully implemented, or if already implemented at the national levels, that they will be improved, that their impact, their efficacy will improve. For the 3 new cancer screening programs, gastric, prostate, and lung cancer screening, there has been, under the EU for Health umbrella, 3 grants issued last year, and the corresponding consortia started this April with these implementation programs. Talking about lung cancer screening, we do know that lung cancer is the biggest killer, unfortunately, within the EU, also within the Slovak Republic. So the most recent GloboCan data tell us that every year about 3,300 patients are diagnosed newly in the Slovak Republic with lung cancer. Unfortunately, about 2,500 will die per year due to lung cancer. But we do know, and there is solid evidence, that low-dose CT-based lung cancer screening will enable us to detect lung cancer earlier and achieve a stage shift from the metastasized stages to the early stages that could be curable. Because nowadays, still, in the majority of European countries, lung cancer is detected late when the disease is already metastasized, when cure is no longer possible. And the idea by low-dose CT-based screening in risk populations on an annual basis will help us to detect this deadly disease earlier so that it can be cured by surgery or other curative means. Based on 10 randomized control trials, the 2 largest one, NLST from the United States of America, and the largest one in Europe, the Nelson study, we do know that low-dose CT-based screening can significantly reduce lung cancer-based mortality. There is also a trend that it can reduce overall mortality in risk populations that are defined by age and also the smoking consumption. And we should be aware that lung cancer screening programs are already going on within the EU. So here in green you can see Croatia. The Croatians were the first within the EU that started a nationwide lung cancer screening program. It's really it's a sophisticated, well-made program with GPs enrolling, motivating people at risk to enter lung cancer screening programs. They most recently presented their 2 years results, which are really promising and go beyond the positive data that we have seen in randomized controlled trials. There are 2 other countries, Poland and the Czech Republic, who have just started national programs last year. All those countries in blue are countries that have already or are currently running pilots for lung cancer screening. And I just heard on the floor this morning that there's a good chance that there will be a pilot on lung cancer screening in the Slovak Republic soon, and I would be grateful to get in contact with those in charge of that. So implementation is already ongoing, and I think it's our task to facilitate these actions, and as Mike Morrissey has said, to come up and to facilitate exchange of knowledge, successes, but also pitfalls to avoid. Lung cancer screening, I think this is also true for the other cancer screening programs, is a complex process. So first, the identification of people at risk and enrolling, reaching out to them is a major step, because as we are aware in many other areas in healthcare, there are definitely hard to reach populations, socially deprived people, migrants, geographically remote cohorts, but we also need to find ways to come up with a structured progress of the original screening process, but also of the workup of the positive or suspicious findings, because one major aim, not only lung cancer screening, is to keep the rate of false positive findings low, because we need to avoid futile invasive procedures which may harm healthy individuals at risk for cancer. This is especially true for lung cancer. On the right sides, you see different points where we have already worked on to come up with effective but also cost-effective programs. We do have already data on successful implementation of lung cancer screening programs. Here you see one paper by Balata on the first results, baseline results of the 5 UK pilots. And they were, like the colleagues in Croatia, also very successful. So the pickup rate of lung cancer at baseline screening was 2%. So if you screen 100 individuals at risk, 2 in the UK were diagnosed with lung cancer. 14 had a shorter follow-up, which didn't prove lung cancer, so they had a shortened follow-up scan after 3 or 6 months, and only 2 had false positive findings, so were undergoing a futile invasive procedure, but no relevant morbidity or mortality was caused by these procedures. So very successful program. And by implementing structured, rigid, guideline-based programs, I think we are all capable to come up with similar results. I am part, and I'm really grateful for that, of the SOLACE consortium. SOLACE is an EU for Health funded consortium with the aim to improve the implementation of lung cancer screening programs within the 27 EU member states. So our idea is to provide, in a toolbox approach, advice, but also collecting experience, like in the Slovak Republic and of course many other countries, what works good, what hasn't worked good in the past, to provide everybody within the EU good advice how to implement a powerful national lung cancer screening program. And of course, we will also integrate smoking cessation. We will come up with a living guideline on lung cancer screening, which will hopefully set the basis for a EU lung cancer screening guideline. We will have 3 implementation programs, and we are very keen to also set up a pan-European research platform on lung cancer screening around. On the map in green, you can see the countries already integrated within SOLACE, and we are, of course, very, very happy and looking forward to collaborate with the Slovak Republic. There are 4 medical societies involved, the European Respiratory Society, the European Society of Radiologists, the European Society of Thoracic Surgeons, the European Radiotherapy Society, to patient organizations, European Lung Foundation and Lung Cancer Europe, and all is under the umbrella of the European Cancer Organization, which helps to coordinate also the two other EU health consortia, which I will talk on later on. Yes, we are ready to implement lung cancer screening in Europe. For me, there is no doubt. The programs are evidence-based. They could be effective. Harms, I think, could be reduced to a tolerable level. We already have evidence that most programs are cost effective. And let's not forget, it's about the individuals at risk for lung cancer. It's not only politics and bureaucracy. And now speaking in a much broader sense, yes, we do need to improve lung cancer screening in Europe. I think that's one of the main tasks within the EU Beating Cancer Plan, because many individuals have already been exposed to risk factors for cancer. We do need to improve the 3 existing cancer screening programs: breast, colorectal, and cervical cancer. I think we are also do need to implement or help to facilitate to implement the 3 new recommended cancer screening programs. So it's not only Solace on lung cancer screening, but it's TOGAS on gastric cancer screening. It's PRAISE-U on prostate cancer screening. And I think we are also obliged to invest in research to explore future cancer screening options. Liquid biopsy probably will be one. It's not ready for prime time yet, but we have to work to find and maybe combine it with the existing screening programs to make them even more effective. And of course, artificial intelligence is another powerful tool that we need to work upon. So in summary, the evidence justifying to start implementation is there. We have the solid basis, the cancer screening in the European document by the Scientific Advisory Mechanism, and from ECO, the European Cancer Organization, we would like to highlight that we have a lot of focus topic networks, and I think the aim of the game is to link cancer screening within the entire cancer screening pathway in a meaningful way, because that's a good way to really take care of individuals at risk for cancer. Thank you very much, and now I'm really looking forward for a fruitful discussion.
Thank you very much. Torsten Boom, are there any questions for Torsten? Thank you.
Dr. Bendova, Slovak Society of General Practitioners. Thank you for your presentation. I've got 2 questions regarding the lung cancer screening. First, how do you want to reduce the overdiagnosis, the case of false positive cases? And the second, you mentioned that in Croatia, GPs are involved in the cancer screening already. I'm interested how, and if also in Czech Republic and Poland in these pilot projects are GPs somehow involved. Thank you.
Thank you.
Yeah, thank you. Both are two important questions. So overdiagnosis is maybe the biggest harm within lung cancer screening programs. So overdiagnosis means we do diagnose lung cancer by screening in individuals at risk, which will not benefit from the therapy of lung cancer. These are especially individuals that are older or have substantial comorbidities. So our aim is, when we enroll individuals, that we have to check for the fitness, not only for lung cancer screening program, but for the fitness for a curative therapy. So in the US, the age range has expanded from 75 to 80 years. So you should be careful when expanding, for example, the age range to higher ages, because when including older individuals, if they are not fit enough, there is a high risk for overdiagnosis. The same is true for individuals with, let's say, a high burden of comorbidities. So there should be qualified healthcare professionals at the entry into a program, just verifying that an individual is really fit and suitable for a program, taking into mind to avoid overdiagnosis. For the second questions for the GPs, so I think there are already two good examples. So one is, as you said, Croatia. So I'm close contact with Miroslav. I cannot pronounce his last name, Samarancha or something like that. I'm sorry for that. So I know Miro quite well, and he is really grateful for his powerful GP network in Croatia. Because they ensure a high enrollment rate, and I think that's the most, or one of the decisive factors in lung cancer screening program, to identify and motivate people to start and to go in the program when at risk and suitable for the program. Estonia is another good example. They had a pilot that was also GP-based in terms of enrollment, and they have had even higher, let's say, enrollment rates than Croatia, something like up to 80 of 90%, so very successful. In Poland and the Czech Republic, I think that they also will build upon GPs for enrollment, but they will also build upon secondary care physicians like pulmonologists, other internal medicine specialists. And I think at the aim, we need to come up with multiple channels that identify, motivate, and help to enroll individuals at risk. So, for example, this could be ambassadors for migrant populations. This could be occupational medicine specialists for workers, at least in Germany, who usually do not see any GP or other physician at all. So we need to be creative, and I think that's also a good example how we could learn from each other within the EU by just exchanging knowledge.
Thank you very much. Another question?
Thanks. What I wanted to ask is, do you have a mechanism of involving also other countries that are not a part of SOLACE to the SOLACE activities? And if so, what you are offering on behalf of SOLACE? Is it protocols? Is it recommendations? Thanks.
So first of all, we are very open to actively integrate as many EU countries as possible. So a first step will be to reach out via the national societies to set up, we will call it national expert teams that help to promote lung cancer screening implementation within their respective countries, but also to have an active knowledge exchange, to learn about the national status quo of the respective countries, but also to provide assistance, as said, in a toolbox approach, how to better implement, like in countries like in Germany, where we are just, let's say, have the bureaucratic hurdle that needs to be solved. So yes, we are open. What will we provide? So we will have a knowledge hub that will be freely available. Online, we will provide an evidence-based lung cancer screening guideline that we will, of course, offer to the EU cancer screening guideline, so that hopefully it will take not that long to come up with an EU lung cancer screening guideline.
Thank you very much. Any other questions?
I see quitting the smoking as a huge challenge within the lung cancer screening programs. Could you please share with us some experience from other countries? Who is responsible for this building block in a screening program? Because we see this in Slovakia as a huge challenge for the future.
So first of all, integrating smoking cessation with a lung cancer screening program is a win-win for both, for the lung cancer screening program because it will become more cost-effective, but also for smoking cessation programs because we do know that the willingness to quit smoking is much higher when we are within a lung cancer screening program than in individuals that are offered a standalone smoking cessation program. To my knowledge, the current status of smoking cessation programs within the EU is very heterogeneous. So, for example, in Germany, individuals have to pay at least a part of the amount. The other part is funded by insurance companies, mostly run by outpatient pulmonologists. But it's different in national healthcare systems like in Denmark or in the UK, where it's offered by the national healthcare system. So very heterogeneous situation, but we do know, for example, out of the pilot that it's possible to successfully link or integrate smoking cessation within the pilots.
Thank you. Any other questions? I think we can wrap up. Thank you very much.
Thank you.
Thank you, Torsten. Now we will continue after a short coffee break. Stefan Kortz mentioned that the networking part is equally important than the expert part. Please note that when you come back after the break, we will have expert panel in Slovak. So if you don't understand or do not speak Slovak, please take the headset when you come back. Thank you. See you in 20 minutes.
Ja by som možno, že zosilnil najprv tieto mikrofóny, že by som im pridal trošku viac všetky okrem kombinácie. A možno, že môžeme, ale už na polke už veľmi viac som nešiel, to nepočalo. A skúsme, ale zosilnil sme, lebo ja som ich zoslabil ráno trošku, lebo aby sme neprepálili stream. Ale možno, že takto to už bude teraz dobré. Môžem vyskúšať. Dobre?
Ja poviem asi aj, alebo to Zuzane, že musia ich mať pri ústach, lebo oni robia
Tá zadná sekcia, lebo tam, keď ľudia vstupujú, tie zadné rady nepočujú nič.
A ten štvrtý mikrofón, ktorý som vám dával, tam je. Dobre. Dobre, ja pozriem rýchlo, či som baterky v pohode. Zatiaľ asi sú. Dobre, počkajte. Ja rýchlo ty ho máš. Dobre. Dobre, okej. Uvidíme, keby ešte trošku trebalo, ja ešte trošku viem zvýšiť ako silu tých mikrofónov, to ešte viem, ale mástra neviem, no.
Welcome back. A little change. The next panel will be in English after all because Marek Krajci couldn't make it today. But it doesn't matter. We will have a quality discussion anyway. Stefan Korec, Chief of Onco Alliance Slovakia, will have a presentation. Please.
Thank you very much.
Go on.
Well, good morning again, and thank you for your patience and staying here. Pardon? Well, okay, now it's okay. Good morning again, and thank you for your persistence and staying here for further continuation of the conference. We've heard a lot about the plans, how we want to do it, about the programs, what we want to improve, how we want to proceed. I'm a clinician, and as a clinician, I'd like to go more down to earth and more down to real life. Okay, can I get them? I'm sorry, next slide. Slovakia is consistently among the countries with the highest mortality rate from cancer in European Union. As you can see, European Union is in the middle, Slovakia is on top, and as the graph demonstrates, Slovakia has almost 100 individuals higher mortality than is the EU average. Again, per 100,000 inhabitants, almost 100 individuals die more than the average, above the average of European Union. What is of interest, that Czechia, who has the similar genetic makeup, is below the EU average, and this signifies that it's not in genetics, that the problem is somewhere else. We think the problem is in the management. The more recent data produced by OECD show that cancer incidence in Slovakia is just about less than 5% higher than in the EU, but the cancer mortality rate is 18% higher. It's almost 20% more, which means that there is problem with management. Also, the 20% more means that Slovak citizens have almost 20% higher likelihood of dying from cancer than is the EU average. That's sad. We have identified several key problems in cancer care in Slovakia. They are not specific for Slovakia only, but look, shortage of physicians, bureaucratic overload of medical staff, inefficient communication between providers, diagnostic errors and duplicities, limited access to innovative treatment, insufficient funding. Of course, there are many more, but these are the key factors what we need to deal with. All these factors together are responsible for major delay in diagnosis. The time from first signs of oncologic disease to treatment initiation is 180 days in Slovakia. 180 days is half a year, which means if the patient presents with early stage of the disease, which may be still operable, by the time we start the treatment, he may be inoperable, and this will significantly reduce his chances for beneficial effect of the treatment. Means we are causing some of the problems. Onco Alliance decided to launch a project, we call it Partner, that we want to partner with artificial intelligence and shorten the time interval from 180 days to 50 days. Yes, it is ambitious project, but I think that with the help of modern technology, more importantly, with the help of physicians and participants, we should be able to achieve this goal. The slide appears to be pretty busy, but it's to reflect the complex approach to the complex problem. The whole journey starts at the level of general practitioner. Patient fills out the electronic questionnaire, artificial intelligence helps to interpret it, helps to create a medical note for the physician, takes in the laboratory results, and creates the note, complete note, including the assessment and recommendation for further management. Now comes the physician who will say, yes, dear AI, that's your recommendation. I am the final judge to decide which way to go. So it's not replacing the physician, but it just is a partner helping the physician what needs to be done. When a physician decides that the patient is suspicious, that there is a suspicion for malignant disease, the system sends a report to National Cancer Registry and takes care of the appointment and scheduling of the patient for specialists. Again, this is one of the key problems here, to get the patient from the general practitioner to specialist. The time delay at this point is almost 90 days. The general practitioners are complaining that if they don't call the specialist and telling them, please see this patient, the 80% of the patients will come back to them, please help me, I cannot get appointment with a specialist. Again, patient goes to specialist, go to imaging. By now, we already know there are several programs with CT reading, which should also speed up the project, speed up the journey, and should also help the imaging personnel to process more patients and to go faster. The patient comes to, the specialist takes the biopsy, the biopsy comes to pathologist. Once the pathologist establishes that, yes, this is the diagnosis, confirms the diagnosis, system sends the report, I stress, sends the report to National Cancer Registry. System is helping. There are several systems ready to help interpret the pathology. Pathologist performs morphological diagnosis when he decides genomic profiling. And again, there is AI-assisted interpretation of genomic profiling. And in the end, the AI assists clinical oncologists, medical oncologists in the decision of further management. Also, the system will create a simplified medical note, which the main medical note shows only positive findings, while in the subfiles, there are all the detailed reports, further saving time for the oncologist and for the physician, that they don't have to read the whole stack of the reports. That's what the patient is about, and these are the specific reports. Medical oncologist is the end user of the system, which means medical oncologist has the input on all stages of patient's journey, from general practitioner, specialist, imaging, pathologist. Medical oncologist tells all the participants, I need to have this, I need to have that, I need to have these specific questions answered. The whole journey proceeds within the boundaries of guidelines from ESMO, NCCN, which are modified by Slovak Oncology Society, which means that patients will get what's necessary, and hopefully we will avoid the unnecessary tests and again speed up the whole journey. Finally, at the end of the journey, the system generates a report for tumor board, which contains medical history, physical exam, diagnostic summary, and all the necessary information for medical oncologists to make appropriate decision and to say, fine, that's what we need. In diagram, it looks like this, that patient with final diagnosis, the system say yes, surgical treatment, no surgical treatment, systemic therapy, if systemic chemotherapy or targeted therapy, if targeted therapy, immunotherapy versus driver targeted therapy. On top of it, very importantly, the system will offer also supporting literature, and if there are no drugs available for agents available for the patient, if the patient qualifies for clinical studies. So this should be a very strong argument for the oncologist. That's what needs to be done. And again, I need to stress, it's just a recommendation. The oncologist has his own information, has his own knowledge base, and will be the final arbiter what I'm going to do and how am I going to do it. So we believe that a successful completion of the project will address shortage of physicians because the physicians will be more productive, will reduce the bureaucratic overload, will improve the communication, will hopefully reduce the diagnostic error and duplicities. A report from United States says that 1/3 of the deaths in the hospital are due to medical errors, which is sad, but it's a reality. Unfortunately, we will not address access to innovative treatment, and we will not not improve the insufficient funding. But yes, we are hoping that we'll at least speed up the whole journey. And most importantly, we believe that successful project completion will save the lives. Will it? Hopefully. Yes, it may sound like a science fiction. It's not. The individual components of the project are already available. All we want to do is to interconnect them, to make them work in one chain, and hopefully to offer it to physicians to use it as part of their daily life. As we've heard already from my previous speakers, artificial intelligence is now becoming an everyday occurrence, and it should become an everyday instrument for the physicians. Hopefully it will. Talking to several medical societies involved in the whole journey, we found out that yes, there is resistance from the side of physicians. I'm a doctor who is going to tell me what to do. But the majority of the doctors are ready to help, are ready to contribute to further development of the system, are ready to help to improve the quality of care of Slovak healthcare. Thank you very much, everybody.
Thank you very much. Stefan Korec will be in the next panel as well. Please take the seat. Jana Bendová, former GP expert of the Ministry of Health of the Slovak Republic. Welcome.
Thank you. Thank you.
Branislav Bystrický, Vice President of Slovak Oncology Society.
Thank you.
Thank you very much. And Andre Carvalho, Senior Scientist, International Agency for Research on Cancer. Welcome again.
Thank you.
Please just hand the microphone to the person that is speaking because we have only two. Let's, please share one and speak as close as possible so people can hear you. Thank you very much. Mr. Bendová, what are the causes of slow diagnosis in oncology from the perspective of general practitioner? What are the main problems in this whole journey that we have seen?
We have several problems. The main cause is, I think, that we need help. We need help with this bureaucracy overload, either the finances for assistant or virtual assistant, artificially intelligent, who helps us to deal with all this.
What kind of help are we talking about?
This project sounds very well. I mean, we are collecting the data, but they are not structured, and they are not of very much help for the specialists because they don't see it if they don't use electronic health records. Either way, if we don't put it into the electronic system, or if the specialist is not using the electronic system. General practitioners in Slovakia proved that they are very capable with electronic systems. During pandemics, nearly 100% of GPs started to use the electronic prescriptions. And at the moment, the number of GPs using electronic sick leave is also increasing, is more than 90%. So I think, even though the average age of GPs in Slovakia is 57 years, we proved that we are able to use such assistance with electronic health records and artificial intelligence. I really think this is possible.
Mr. Bystrický, is it about sharing the information between the general practitioner and the oncologist? Is it about the journey that Mr. Korec described?
Definitely, I think so, because it's one of the things that patients experience delays. When patient comes to our clinic, I have to really fetch all the examinations. You know, the CT scan was done in another city. I have to call them, send us the pictures so we can look at it at the multidisciplinary meeting to show the surgeons, to see where is the pathology, where was it taken. It was another city again, so we have to write there, please do the genetic testing for the mutations that I require, and I have to put my stamp on it. So everything, there are delays with all these things. So when it comes back, it's 2-3 weeks pass, and we are just waiting for the results, waiting for the genetics before I put the patients for the tumor board.
But we are talking about electronization of the system for like what, 10 years now? So
yeah, but this is the daily practice. This is how we do it, because electricization is still in infancy.
So a lot of stamps and paper.
If the patient has, let's say, a laboratory test done in another hospital, I don't see it. I have to repeat it. If it's not in the documentation from the GP, let's say tumor markers, we take them again. Useless, but it's true.
Duplicity. Mr. Korec, who does benefit from this chaos? Why is it still so chaotic?
I don't know who benefits from it, but I know who suffers the most are the patients. I don't think there is a benefit to this system for everybody or anybody. I think, yes, there may be this jungle may be helping some people who with speculations, maybe helping some pseudo-physicians, some people who try to use the paramedical help, not the scholastic medicine, but no, I think there are no beneficiaries, there are only losers in this system. As long as we are in this jungle, I think there are only losers here.
Yeah. Andre, how do you perceive what you have just heard about the patient's journey, and are there any examples which we could learn from in other countries?
Oh, sure. I think data is crucial. Sharing data as well, because we're talking about, from GP, primary healthcare level, to cancer center, tertiary. And this is a journey, as been put it. The IT system proposed can help with the information, but I guess need also a restructure of the referral pathway, right? Making sure that the GP knows where to send the patient for confirmation of diagnosis, and once the diagnosis is done, where to send the patient. The sharing of the data, the creation of these it takes time, right? And in screening, we have one say that's the fail-safe mechanism, meaning that everybody that's positive should not be left behind. So if the patient that has a suspicion of cancer doesn't go for the next step, somewhere in the system knows and goes after that patient, because some patients are lost in the process, right? So it's kind of this patient navigation, this referral system. As an example, during this project that we're doing is Slovakia and Latvia. And Latvia doesn't have yet the IT system that share all the information, but they create what they call the green corridor, that once someone is suspicious for cancer or has a diagnosis for cancer, there is a number, a hotline that's called, and they help the patient to get to the next level and eventually get to the cancer center in a very expedited way, kind of less than 60 days. So this is a possibility that can be created, that, there is a number. And we visit the place in Latvia, right, and everybody knows about the green corridor, the GPs, the diagnostic centers, the cancer center. So I guess there are mechanisms that we can improve the referral pathway and make sure that everybody that has cancer or suspicious for cancer get diagnosed in time, get for the cancer center in time, while we have this wonderful solution that we're going to take some time to get there.
Let me ask about the hotline. So you call the hotline, and then what?
They make sure that the appointment's made for the diagnosis, and then after the diagnosis, they make sure that the patient gets to the cancer center. So it's about the patient navigation. It's about helping the patient to navigate the health system that's always fragmented, and it's complex when you go from GP to the cancer center.
Well, this sounds like a distant future for Slovakia, right? The hotline where somebody would guide you through the system.
I am hoping that it's not such a distant future, and I'm hoping that the system will solve it without having to call. We had the virtual waiting room there. As soon as the GP wants to send the patient, decides to send the patient to the specialist, send a patient just to virtual waiting room. The virtual waiting room will notify the specialist there is a patient with suspicion, and there will be a red light blinking on his monitor. There is a patient in waiting room who is suspicious. And if nobody, if the general if the specialist doesn't accept the patient, or there are usually 3-4 specialists for every GP, you are not sending just one gastroenterologist, 3-4 of the gastroenterologist to whom you send it. If none of the specialists will accept the patient, then somebody else has to intervene. Is it insurance company? Is it the organization? But somebody has to pick up the phone. Hey, 4 specialists, you see for 4 days, the patient has been waiting and nobody reacts. So yes, we think that their hotline should be replaced by the virtual waiting room.
There was a very good point that the patient is really lost in the system. I cannot help each of my patients with a suspicion to call to the specialist. They are often not available on the phone because they are working, okay? Yeah. They're not responding because they are busy with their work. The analysis of oncological care in Slovakia shows that, for example, for colorectal cancer screening, we have a major role at the moment. We are distributing the tests, and the patients are coming, and only 40% of positive tests, the patients go for colonoscopy, and 60% is lost. They didn't make of the positives, yes. So only 4 out of 10 go to colonoscopy. Why? They are lost. They didn't make an appointment with the specialist, or maybe they are afraid. There are several reasons. But really one of them, major of them, is they do not have the appointment straight away, leaving my practice.
Mr. Bystricky, how many calls do you get from just, your circle of friends if they are desperate to find a specialist? Because I can imagine in Slovakia people know each other,
yeah,
right?
It's, I will tell you one example from last week. Patient came to us, visited the surgeon with a new growing lesion on his arm, and he was referred for magnetic resonance, and the appointment was in September. So he came to our clinic, even though we have seen him first time, begging to see if we can do something for him. No diagnosis yet, but fast-growing mass, most likely sarcoma. And the appointment was obviously the orthopedics won't operate without magnetic resonance. They need to see which muscles are infiltrated and if it's not infiltrating the joints. So it's obligatory examination, and the appointment is September. It's a private company who has 20 appointments a day. They won't do 21 because it's not being paid for by insurance companies, and so it's a problem. So we have to juggle some of our patients and give him a sooner appointment.
The way the system should help the screening and support the patients who take part of the screening is that they should see if I am screened and if I am already detected, I have detected some problems, yes, I'll be managed expeditiously. I have a patient now who detected, he was a highly disciplined guy, detected blood in his stool in January. General practitioner saw him in February. First colonoscopy in March. The person who did the colonoscopy wasn't able to help. Next appointment with specialist who performed the specific colonoscopy is in July. From January, he was highly disciplined. He did his fecal blood, he detected blood. July, half a year is lost. So we hope if we speed it up, that this will encourage the patients to participate in the screening.
I also see the other part of this that everybody knows everybody or is a family with, that if you have a family or a friend there, he helps you to get the appointment earlier, but the really sick patient has to wait. Okay? So this is not fair, and we really need to put on a fast track the person we have the suspicion.
Yeah, but I think that's the thing that if there is some suspicious for cancer, the patient needs to be fast-tracked. I think in the UK they have something that 2-week rule from diagnosis to treatment. So something like that we need to do in the diagnosis setting, not in the treatment setting. Let's say for us, we can in 2 weeks we can do chemotherapy, radiotherapy. That's okay. But the problem is where the patients are losing time. It's during the diagnostic process.
Well, then that next question is, so I have a displaced disc, right? It's not about me, but it's like anecdotal evidence. So, and my doctor told me that I can pay for an MRI. It was on Saturday in the morning for 300 euros, and I could get it like in 3 days. So are we moving forward to healthcare that is for rich people, that you can pay for the MRI if you have enough money, and then sick, poor people are waiting for the diagnosis? Is this the system nowadays?
I think it's the exception. Not in all centers are taking money and doing MRIs, let's say, on Saturdays, but I think there is not a political will that would show what's its standard in Slovakia and what's a higher standard. Nobody wants to say that.
Because I don't need the MRI. I was just curious about my disc, you know, after 4 years of exercising, and I can imagine then some sick patient could have the MRI instead of me on the Saturday morning, right?
Exactly, yes. Unfortunately, you're right, Dr. Bystricki is right. Yes, you have to pay. Yes, the question was highly appropriate. Are we heading towards a system which is good for the rich? No, we should have the good baseline system for everybody. Yes, the system is not ready and will not be ready in the short future to give best care for everybody. There is just not enough money, not enough physicians. But the baseline should be for everybody. And yes, if you want to speed it up, you may have to pay, but everybody, regardless of their money or their having money or not, should have the baseline. How to establish the baseline? Braňo, you touched it.
Well, it's difficult because on one hand we have a lack of resources, lack of physicians, and also there is some cap on, let's say, on diagnostic processes from the insurance companies. You know how many, let's say, examinations can certain clinic do, and otherwise about that it's being done for free.
I would like to come back that, you know, the fragmentation of the system allows all those gaps, right? And the pressure comes if you need 25 exams a day, not 20, and the machine is ready to do, should not be the medical insurance company that decides I pay only for 20. Because if the need is higher, negotiation needs to come. But you only can play this if you know the numbers, if you know how much you are missing. The other thing that usually day in, day out, they're going to do 19, but they're not ready to call someone that's in July, say, come tomorrow, because, you know, someone did not show up. And only when you have intelligence on the system that you can track the patient, that you can track the services, is that you can fill those gaps, then can help you to shortline the time line of the diagnosis and access to treatment. The health system needs to rethink how they do. decision on demand or no, decision on payment should be on the demand needed for the population and not, I would stop in the 20 if the need is 25. And that needs to be rediscussed.
Yeah. So, can the system, Mr. Corres, help save financial resources for the state, and not even financial, but also the personal resources? Because we have less doctors, we have less physicians. So, is this gonna help with the money and the people that are missing in the system?
Yes, the answer is strong yes. Yes. I have 50 years of experiences in 50 years of practice of medical oncology under my belt. And yes, I believe the system will help. I believe that it's a time, the time is here, the technology is here to help. Yes, we will reduce the bureaucratic burden. What is it, 30%, 40% of your time is paid paperwork? If we can save physicians 40% of the paperwork, or just reduce it to half, it already helps. If we can save the physicians the time where they need to check for previous tests and they don't have to repeat the test, it will save the money. If we can have the unified medical note, which is simple to read and yet contains all the details, if we can have the genomic analysis, which will tell us whom to treat and how, or just go back to the standard, it will save us money. If we can improve the communication between providers, it will save us time. So yes, the system will save money, will save the time. Yes, the system will be more efficient. And yes, it will improve and increase the productivity of the physicians, because less paperwork, more physician work. Yeah, the answer is yes and yes.
Is it 40% of your work, the paperwork? Is it accurate?
Well, if you need to write request for expensive drugs to health insurance, even more than 40%. Because when the patient comes, you just write and type, all the summary of all the records, histology show this and that. You rewrite the CT scan, you rewrite markers. Are you feeling well? Okay, tomorrow chemotherapy. So yeah. And
so more than 40%.
Well, then you take the charts, and during on-call hours you do the you do the submissions for some expensive drugs for insurance companies. So.
In our general practice, we have a very recent experience. We changed the program, the software for our practice, which is based on a lot of automatization. And it's not 40% anymore of bureaucracy. So we experience it works. It can help us.
So how many is it nowadays?
30.
30.
But it's in 2 months. We are not using the system 100% now because we had to learn a lot. But I think it will be even better.
But is it optional? It's optional,
Yes.
the system, right?
There are different systems. We used one for 15 years. Now we changed because we had a recommendation. It's working this way, and it's really working this way.
So how demanding is the preparation and implementation of such system? Like, I can imagine that it will be difficult.
It's not easy. Definitely it will not be easy. But as I mentioned at the beginning, we expect about 10% of the physicians to participate. If we have 2,000 general practitioners in Slovakia, we hope that we have 200 of them to participate,
Like
especially
in the pilot study,
Yeah.
which means the 10% of the physicians who will participate are most probably already digitally literate. They know how to use the system, so they can just go one step higher. Yes, it won't be easy, but yes, we will work with people who are not beginners. So we are very optimistic that it won't be that long. I cannot tell you exactly if it's 3 weeks, 3 months.
Okay, but except the practitioners, what other can be done in the pilot system?
Of course, the start and the main stress is on the general practitioners. They are the ones we need to work with very closely. They need to be given more responsibilities. And of course, the next step, the specialists, We know how long is the waiting time for the specialists. We need to tell them. Specialists are complaining. GI practitioners tell me, and you don't have to listen now. GI practitioners tell me, GI specialists tell me, oh, the GPs are sending just the patient GI and don't tell us anything about the patient. May not be true, but yes, the specialist will get full report of everything. He can read it in 2 minutes, which will save him time, doesn't have to search for CTs, doesn't have to search. It will save him time, and again, we need to work on the specialist to accept this unified note, which will float back and forth all the time. Next step is the pathologist. The pathologists are already starting a project of national digitalization of pathology slides, which means it's a national project which already has a European EU funding, and they are already preparing nationwide digitalization of pathology slides, which will make it much easier to subject it to AI reading. And finally, the oncologist. What the oncologists told me, several oncologists, well, if you provide us with that amount of data on one page, that's the dream. We just have to look at it and make decision, go, don't go. So oncologists, I think, that's the group which is most prepared and ready to highest extent. And as you just mentioned, Janka, I'm really very impressed by you using the new system, so I think it will be much easier with general practitioners as well.
Yeah, you probably will be in the pilot.
Sure, I already promised.
Okay, so, but definitely you will need cooperation with different fields, right? So, Ms. Bendova, what kind of obstacles do you see from your perspective in the implementation of the system?
We really suffer with a lack of staff and finances. We would need finances mainly for have more staff and also more competencies for the nurses. To be able to employ one more nurse and to employ assistant, really. We suffer much that we are doing their job because, yeah, we don't have enough finances for them. And also, we would need more competencies. Would you imagine that 3 years ago we couldn't send a patient to mammography? Preventive mammography?
Why?
It was just blocked. They had to go via gynecologists, but it was changed recently. Okay, just an example. Obstacles which I don't understand.
So, what are the obstacles from the perspective of an oncologist, Mr. Bistritsky, if there are any? Because Mr. Koret said that you are better prepared than the others.
Well, I think better prepared. I think the obstacles are what Janka was saying as well, that the lack of resources and staff, but I think it's also the problem that sometimes we can talk about it, that sometimes the GPs, they say they can't write, let's say, requirements for a CT scan. They can't send the patient for a CT scan because either it's not paid or it's increasing their expenditure. So that's the problem. As for more competencies for GPs, I would vote for that definitely. But also I would vote for the GPs that are competent themselves to do it. To, let's say, prescribe medications. But for us as oncologists, I think we would welcome that definitely. If we can have it kind of streamlined, as I was saying, with all the delays and they are eliminated, I look at the labs from the other hospital, I have the CT scans at hand, which I can, download and look for the radiotherapy, let's say, that was done in some other city. Excellent. I don't have to, call anybody else to send it.
Before we get to the EI in healthcare, is there any question from the audience, please? Yes.
Oh, thank you so much. My name is Pernilla Gunther. I'm representing the European Commission today. I'm a member of the Cancer Mission Board. I'm just wondering, since the healthcare systems are so different in different countries. But I'm just wondering, in some countries, I know, and for example, I'm from Sweden, and we have some kind of, healthcare standard in a systemized, healthcare that we know the time limits. If you get a diagnosis, or at least you have some kind of suspicion when you go to the GP, and then you're sent to a specialist and you're diagnosed, you can also see within a time frame that this and this and that will happen in a certain amount of time, and you are very well prepared as a patient. You know where to go and which kind of treatment you also will have in this time frame. I'm not sure if it's applicable in Slovakia, but I think since I'm also a former member of parliament, I'm also curious, how do you experience your demands from policymakers? I mean, it's also a question about patient safety, I would say, to really bring the patients in time to really get their diagnosis and, of course, their treatments. We will have a session later on today about how much cancer affects the society and the costs for society. But to increase, I mean, the prevention and also to listen to you as professionals and to increase patient safety will actually save money. So I'm just curious, because I think one of our main reasons to have a cancer mission board is also to be able to implement the Europe's Beating Cancer Plan. And I think the policymakers, together with healthcare professionals and patient organizations, are really important to work together to increase the implementation. It was a long question, but...
No problem. So 2 parts of the question. First is if we have any standards for waiting time for a patient, or like a journey that a patient could see where to go to. And would it be applicable in Slovak system?
Well, yes, Sweden is quite far away from here, not only geographically. Sweden is quite far away from us also in money supply. So yes, we can have standards, we can have limits, but it's impossible to apply them. What do you think?
The same, unfortunately.
Mr. Bystrický, Andrej?
I'm not aware of any time limits that we have so far that would be kind of imposed or that we have to, stick to and be kind of sanctioned or incentivized. That was the other thing. If we can, that was the other thing, maybe not do it kind of, put some incentive if the patient is diagnosed sooner or if he starts treatment sooner, to put some intensive incentive to the healthcare provider for such a patients. That would be also, good.
Andrej?
I agree completely. Health systems are different, but goals are equal, right? And we need to work on that. Solutions are going to be context, right? But if we don't know the data, we don't know what we need to improve. And some improve comes natural. Maybe from 180 to 50 takes longer, but maybe for 180 to 100 to 90 is achievable. Maybe in Sweden it's just 30, right? But we need to decrease that. 6 months is not the case. I'm originally from Brazil. There was a law there that 90 is the limit. Not 60 because it's impossible, but not 180. So I think the goals are the same. We need to help cancer patients to get as fast as they can diagnosis and treatment. Set the goal. Don't start, eventually in 5 years you're going to have 50 days. Just go. It's 150, then 100, then 90, and you begin to improve and look at that, what worked, what didn't work. Solutions are different.
Okay, and the second part of the question was if you get any response from policymakers. And since I'm a political reporter for my whole life, I mean, my commentary to this would be that sometimes people go to the ministry and it's too complicated to solve the problems, and sometimes members of parliament do not understand the issue. So Maybe your comments on this about the policymakers?
The support has always been declared, the political support, but the reality is different.
Is it too complicated, or what is the main problem?
I actually don't know. Maybe the reason is that the politicians change very often. The main survival of our Ministry of Health is less than 2 years, as far as I know. So the continuity is missing, and as I was the chief expert for general practice, I worked with 2 ministers, and I came with one and with arguments, and we started doing something, and it changed. So the person changed, and I had to start again with the same.
Mr. Bistritsky, what about the policymakers?
I think I agree.
So continuity.
Yeah, continuity is one issue, and the other thing is that sometimes, at least the laws that are being passed are really not being discussed with the specialists, you know, and their impact are being just passed so they get some political points, and not really with what we really need in the field. You know, we need this, but it's too difficult. Rather, let's pass some other law, you know, that cosmetic law, or that we have, yeah. You know, there was a law passed recently that we have to report to the judges if we restrain the patient. Nobody knew about it, that such law was passed, and now we have to report every day if there are some use of restraints for patient who is agitated just for a day or for a short while. That's another bureaucracy.
More paperwork.
More paperwork. And every day, every 24 hours, you report to the judge.
Cool. I didn't know about that. Andre.
I would like to stress what you start is communication, right? I don't think we as specialists, highly specialized, are ready to deploy the information that the policymakers are ready to read and listen, right? As a scientist, I would like to show survival curves, p-values, and half of people will not understand what I'm talking about here. And I remember I was with the CEO of my hostel once. We got an audience with the Minister of Health, right? And I was there as a technical. I began to put this, and my CEO said, stop. Because the minister got lost, right? And then he said, let me start it again. To the minister, he said, you can save lives, right? Let's see how. It's kind of, we are not prepared, and we also need to do our homework when we have a chance to talk with the policymakers, how we talk in a manner that they understand their role and their importance in the system.
Mr. Koretz, policymakers?
Yes, policymakers. I'm still looking at our Mrs. Dolinkova here, who is the representative and hopefully will be one of those key players in the future. We had a Minister of Health who is highly highly committed to help. We've heard him.
Yeah, but he's leaving in 6 months.
Yeah.
Yeah.
Well, that's fine. That he should give the message to his, hopefully, next guy who comes in line. But yes, it is one of the reasons of having these conferences, to have people here from patient organizations, physicians, international organizations, and we thank you all for coming here to Bratislava to support us, is to make the system, make the politicians aware of the problem, of need to address the problem and need to help. Yes, the pressure is mounting. Yes, many political parties have the healthcare as an issue or number one or top of the issues in their political programs. So we are hoping we'll just keep building the pressure, and we are hoping to get more help. And I am really hopeful that the future government will be really supportive.
Yeah, well, pity that Marek Krajci is not here, because he could have done something as a Minister of Health. He didn't do that much. Okay, but COVID was there, to be fair. Another question? Yes?
So hello, everyone. My name is Anna Dodea. I'm the Managing Director of MSD Slovakia. And first of all, I would like to salute the presentation of an AI-powered patient journey potential project. I think this is really great, and while Sweden is a little bit further away, I think Czech, Poland, Romania, Bulgaria, they're quite close to us, and I know for a fact that they're already looking at very advanced projects to utilize artificial intelligence to optimize patient journey. So I had a very similar question as the lady from the EU Commission here related to the role of policy making. Because yes, while policymakers may change, I think this is in the nature of things, I think policy for healthcare is really important to be consistent and look at the patient outcome. What is the best for our patients? What is the best for the wealth, let's say, of our country? And to that, we are all aware, and I should say that patient journey is difficult everywhere in oncology. There is no such thing as a perfect patient journey anywhere, and I think Andrea here and some other colleagues can confirm that. And we do know that resources are limited. So on that note, and thinking about consistent policies that support oncological patients, my question to you is, knowing what are the key mortality drivers in cancer in Slovakia, would you see a room maybe, and talking about, policymakers in this room, do you think there is time to have a discussion about prioritization, talking about fast track and the green corridor for the patients? Do you think we can potentially open a conversation about what needs to be prioritized?
Thank you very much. I'm sorry, maybe I'm talking too much. On my first graph, I have shown that the mortality rate in Slovakia is almost 100 cases per 100,000 citizens, which means this is a tragedy, and this makes it so urgent that the policymakers will react, and we just need to show it again and again. Those data may not be absolutely reliable, but yes, Anna, go ahead.
To kind of nuance a little bit my question, looking at the main tumor types that are driving the highest mortality within the overall oncological disease spectrum.
Like breast cancer, for example, for Slovakia, I guess. Yeah.
Prostate, colorectal, and things like that.
The question was?
If we should prioritize, for example, breast cancer, that we are clearly behind the other countries in the EU. If we should prioritize some of the cancers first.
Yes, we have identified 3 or 4 cancer diagnoses, which are almost 80% of cancer cases here. Lung cancer, colon cancer, prostate cancer, breast cancer. Yes, we like to address those cases at first, in the first line, first approach, but we need to think further on to, again, widen the spectrum. But yes, you're right, we'd like to start with narrow focus and start with the most frequent cases and hopefully get more support.
Mr. Bystricky, should we prioritize types of cancers?
I think it's kind of double-edged sword. On one hand, yes, you should prioritize when the resources are limited, but on the other hand, you should make sure that you are not gonna put on the, on the back seat some people with other cancers who also needs to be treated and needs to be treated speedily as well. So it's a little bit, for a pilot project, of course, you can select, let's say, a patient with GI cancers and speed their diagnosis, open the waiting rooms for gastroenterologists for, speedier fibroscopy examinations, either upper or lower fibroscopy, and maybe do a pilot project on that, get the pathologists on board who are specializing in GI cancers as a pilot project, but then you still should kind of think about other patients that are there, that they shouldn't be, waiting even more.
Well, maybe this is a better question for prevention, how to focus on prevention of the types of cancer we are worst at. Ms. Bendova, do you think we should prioritize any types of cancers? Maybe prevention. Breast cancer is very
It's for me difficult to see the population point of view
Yeah.
because I'm really working with the patients. I have a mother of 3 children in front of me, and I'm looking forward to help her as much as possible. And I don't think of type of cancer she has. You know, it's not that important from my point of view.
Any other questions from the audience?
Thank you very much. Simon Dres from the European Commission from DG Reform. We are together with IARC supporting Slovakia and Latvia on this project. One brief comment before my question on this question of prioritization. I think one thing is also to look at the distribution of the risk factors and the distribution of participation rates in the screening programs by educational level, by socioeconomic level. Because I think rather than prioritizing between cancers, we see that in Slovakia the variation is really very, very large when we look at tobacco consumption, when we look at obesity, when we look at participation in screening programs by educational level. And that links to my question, which is, thank you for the presentation. I think it's a very interesting program that you're working on. My question is, how do you link with the cancer registry and how do you link with a potential screening registry? Because I think on your chart, you are starting with GP referral after suspected malignancies or first positive test or clinical manifestation. So what about linking with the screening programs? Because then what we found in the project is we have no recall mechanism. We have no follow-up to those who are not participating or who have positive results and are not coming back. And those are very often the ones who cannot because they are working, because they lack the information. So it's exactly those people who are in the lower socioeconomic groups or also in areas of the country that are maybe less well off. So linking with the screening program would possibly allow you to really track those people that are currently falling through the cracks at different stages. So is that planned to link with your program?
Absolutely yes, absolutely and definitely. But if we are about to start a pilot project, which already by itself is so complex and complicated, yes, we have it in the back of our mind. It's not just a back burner. Yes, we are trying to talk to people and to influence them. Look, if you follow the recommendations for screening, we are offering you a good track to get faster treatment. This should support the screening, and also we are planning to definitely connect with the screening programs to get another input, not just opportunistic presentation. I have a problem, doctor, let's go. But yes, doctor will get also the reports from the screening. And on the graph I have shown at 3 separate spots how we report to cancer registry at the beginning from the general practitioner, pathologist, and medical oncologist when the final staging is done. So it's a data collection, screening connection. But yes, in the pilot study, that's why I was talking a little bit narrow spectrum of diseases, because we need to start at certain point and we cannot go too wide, too broadly. But yes, screening absolutely yes, and we are hoping that this will encourage population to participate in the screening, because if you participate, this is what we are offering.
I have nothing to add. Yeah,
well, maybe part of the question was about the patient and obesity and smoking. So what about the responsibility of the patient? Because we haven't talked about that yet.
That's a very good question. What I'm experiencing in my practice is that Slovak population is very passive. They're coming to us, let's do something with me. They do not take over their own responsibility to change their lifestyle, to quit smoking. They go to X-ray, they ask to go to X-ray, they come with a clear, normal X-ray saying, oh, I can continue smoking, you know? So if you put them on a screening program with CT scans, they might come with the same result. If it's not connected with smoking cessation, there will be not improvement in survival, I think.
I'm a very passionate anti-smoker, so I will continue my work. Another question.
Thank you very much for this fruitful panel discussions, very worthwhile. So Germany is very close to the Slovak Republic problem-wise, definitely. So it was very familiar what you were discussing about. How about data security for your very worthwhile project? Has it been a problem or is it a problem? because in Germany, data security regulations, namely GDPR, seems to be an independent risk factor for cancer mortality by slowing down these kind of digital projects. Is it a problem here as well?
So GDPR is slowing down the process?
Yes, definitely in Germany. So we have problems, as you said, linking or using clinical registry data for these kind of projects because the patient consent is not enough. Things like that, what we desperately need in cancer care for quality assurance and improvement.
Yeah.
The whole communication channel will run on a double or triple secured in a double or triple where which has all the EU certificates, all the international certificates. This was one of the prerequisites before we started talking to companies who would participate. Okay, how do you guarantee the security and the data security, the safety? And the answer was no hospital, no private practitioner can reach the security level what we have. So this was one I understand, and thank you very much, because most of the bureaucrats come, oh, what about security? How come you want to have the report being moved back and forth? That's what Andre said. The same report will be moving back and forth. Yes, it will be moved, and it will be on extremely secure.
Yes, but that is the data security. But the question was about the GDPR consent, right? Because every time you implement a new system or you share new information, you have to go to the patient and get another consent for another information. That's the GDPR legislation. So how to deal with that?
By now, there is a problem in Slovakia that the doctor or the doctors can share the printed report. The patient can, the doctors will share the printed report, but they cannot share the electronic report. So we are hoping that this will, again, we need to have further approval by the politicians. Hey, if we can share the paper report, let's share it. We need some legislative change. Yes, absolutely. Thank you for specifying the question.
No problem.
I think the GDPR is an issue, but what is interesting is that GDPR is throughout EU, but each country interpret differently what means data protection. Everybody's looking for data protection. Let's protect the patient data, no question about it. But you have countries that figure out how to share data information, thinking that this is a person that, the GP and the oncologist in the tertiary, they need to understand that he cannot only have the data that he got without the data that she gave to him. So in the public health sector, we need to re-discuss this, how this is interpreted. How can you have in Slovakia that if the patient got you on paper, it's okay to share, but not electronically? So this interpretation, that the data, how you share it. And some countries share everything because it's the patient's right to have their health, and this means having access to all his health data. And some countries don't share nothing, and it's the same law.
Yeah. So far, we implement GDPR in Slovakia mostly how not to answer questions of journalists on the ministry. So, yeah, that's the main reason we don't get the answers. Okay, any other questions?
Thank you. My name is Michael Stanag. I'm from the National HTA body in Slovakia. We're the ones on the end of the trajectory assessing the drugs coming in. I guess my question is about the realistic time frame. So you say how to shorten the journey. I guess making a comment on Andre's point about the limits on how many screenings, how many MRIs can be done a day. Within a limited budget, there will always be a limit to that, right? So that just will be there. In the Slovak context, what do you expect? How can that be shortened? What is the realistic time frame that you, if you pick a specific diagnosis, how long can that take for a breast cancer patient to go from first symptoms to initiation of therapy? Thank you.
The realistic journey.
talking about how realistic it is. How do we expect this to work in association with the screening? I don't know. I'm hoping. We cannot predict. We are hoping, we know, and we've heard how difficult it is to have people, even if they have detected blood in the stool, only 40% of those will proceed. We are hoping to have this for them as a chocolate for the screening population. Hey, follow, this is the sweet stuff, let's go there. No, we don't know how many and what is the extent of cooperation, but we are hoping to get more and more, and I don't know, can you answer it?
We identified really many problems during the journey, and we are at the beginning to do something. Maybe we can do with the communication that we share the records that assists to find the important information, because sometimes I print the report and I highlight in yellow what is important that shouldn't be in 21st century, I think. So also the call center could help, okay, to make appointment for the patient. So there are several steps, and we have to start to improve some of them, which we can influence with this system, with this assistant, artificial intelligence, which we cannot influence. They have to wait, let's say, until the political situation changes or until we find a solution to have enough GPs, enough nurses.
Andre?
The magic number, right, and nobody really knows where it came from, seems to be 60 days. 30 days to confirm diagnosis from the suspicions, 30 days to start treatment after. The WHO is using the 60-day for the breast cancer global initiative, and they have some studies that show that if it takes more than 6 days, the prognosis change. But of course, you have some type of cancers that you cannot take 60 days, right? Brain tumors, some of the lung tumors. You miss the opportunity to treat surgically if you take 60 days. And there are cancers that can be longer, right? Some prostate cancers, it's low grow, but the average magic number seems to be around 60.
But it's magic. What about the reality in Slovakia?
Well, we heard the reality, but I think the answer to your question and what you say would be, let's say, if the patient comes with some symptoms, you know, either a mass in the breast or maybe blood in the stool, or so 2 weeks for the appointment for the specialist, then 2 weeks to get the histology. Usually, it takes them 10 working days, so that's 2 weeks. So that's a month already. Yeah. Then you have 2 weeks for the surgery, so that's 1.5 months, and then you have 2 weeks to get a definite histology and to start treatments. So that's those 2 months. That would be, yeah, and I think it would make us all happy. Yeah. If you have those 2 weeks between
I completely understand, but I think that the question was, what is the real number we could get to, like in several years? So target is 60, okay. And what is the reality? Yeah. So what? Are we talking about 100 days, like in 5 years? What is the real goal that we should aim to? Because, you know, as Andres said, you know, we cannot get the perfect situation in 5 years. We have to be real. So what would be a suggestion that the real number is, like, let's say in 5 years?
3 months.
3 months is 90 days. 90 days is closer to 60 than 180 days. Again, I am being called pathological optimist, so I still hope and believe in the 60 days, and we will be aiming for the 60 days at the beginning. The reality may be 90 days. Yes, this is Slovakia. Yes, we need to respect the local environment and the local conditions. But yes, we will be aiming for 60. But yes, maybe realistically, what Andre said and what Branil said, yes, maybe realistically it's going to be 90. Thank you.
90. Andre, you wanted to add something?
Just a bold estimate, you can drop quickly to 120 just for understand the referral pathway. This is a quick drop. From there on, you need an negotiation to go from 20 to 22 MRIs, you know, but reorganizing, right, give you a drop of a month easily.
Just a brief question. If the time counts from the first symptom, how will you influence the patient factor? Because this cannot be influenced by a worthwhile digital project. So the patient has to come to the GP, has to be aware of the symptoms, which are sometimes not specific, especially in lung cancer. So how do you plan to influence the patient's awareness that it may be cancer?
Yeah, well, I would imagine that text messages would be great, but
not really. I think we plan two different ways of entry, ports of entry into the system. A, patient comes for regular annual checkup. He answers the questions in the questionnaire, does not even know that some of the questions will raise the suspicion for cancer. He doesn't even know, but the system will pull it. We know, for instance, pancreatic cancer, just for history, the AI can pull out the indication for pancreatic cancer, which clinicians were not able to do. So we are hoping that the system will pull out the signals from the history and from the questionnaire. The second one, when the patient comes with the complaints, he still doesn't know if they are or they are not a symptom of a malignant disease. The GP may not be sure, but the system will say, yes, with this and this and these symptoms, GP, be careful, this may be malignancy, consider sending him.
Two things. One is the tradition. The GP here is really the first contact. So if the relationship with the population he takes care of is very good, the patient come with the symptoms, okay, because they trust GP. Either he will say this is nothing, you don't need to worry about, or you have to go there and there. A second is we have a very good system of these preventive checkups which are not annual but biannual. So every 2 years you can go to preventive checkup, which is for free. And the number of people attending these exams is increasing because the health insurance companies implemented a system of benefits. For example, if you need a dentist surgery or something, treatment by surgeon or by dentist, it's not paid by health insurance company if you didn't go to these preventive checkups. So it's really working, these positive incentives to the patients.
I think the one answer to your question is also the health literacy of Slovak citizens, which we need to improve. So that's the problem. Yeah. Because the patient can have symptoms for 3 months or can have symptoms for 3 years almost and comes to the GP when he's spitting blood and lost 20 kgs and it's too late to do anything and he's not fit even for other examinations. So that's one thing, the health literacy that needs to be taught in schools and kind of repeat to the young people and start from the young. And the other thing is the cancer still has a taboo and the patient comes late and when we asking why did you come so late, oh I was afraid, what was I afraid of? I was afraid of cancer. So that get this kind of get the notion that the cancer is actually curable and doesn't mean a death sentence.
But back to the preventive checkups, we usually see always the same patients coming every 2 years. And there is a portion, about 10%, who I never see, who do not appear. And from my experience, these are the vulnerable population. Alcohol intake, smokers, they know we will find something, okay? So they do not want to know about it, they are not coming.
I missed several checkups during COVID myself, so maybe the COVID didn't help, right?
Beginning we were scared, of course, and the preventive care and also oncological screenings stopped. But then because of the health insurance companies' initiative, we were like overflooded with the patients wanting an appointment because of the dental care. So I think the backup is nearly zero at the moment.
Very quickly, right, you brought attention for one. So the journey delay, you have the patient delay, the professional delay, and the health system delay, right? And we have been talking a lot about the health system delay, right? You brought the patient delay that we need to, but we also need to talk about the professional delay, because we count from the first time that they go for the GP, and that's what we're talking about, counting the journey, because it's really difficult to say when you really start to diagnose and make a very accurate timeline on that. That's what we need to guarantee when first encounter with the health system, right? But we need also to understand that not all health professionals at that point will think about cancer. And that creates some delay there as well, right? So, and I think, working, strengthening the health system, training the health professionals, and patient awareness is a trio that we need to organize to decrease this pathway.
Thank you very much. It was really interesting. Andrej Carvalho, Senior Scientist of International Agency for Research on Cancer. Thank you very much. Branislav Bystrický, Vice President of Slovak Oncology Society, Jana Bendová, former GP expert on Ministry of Health of the Slovak Republic, and Štefan Korec, Chair of Onco Alliance Slovakia. I hope you are hungry because we have the lunch break now, and we will see each other at 1 o'clock precisely.
akože nejaký... Môžeme? Pekný dobrý deň, teda ďakujeme, že ste prišli na túto malú tlačovú konferenciu pri tej príležitosti, že tu naozaj máme zástupcov dvoch európskych inštitúcií, ktoré sa zaoberajú rakovinou, alebo teda bojom proti rakovine. A možno na úvod by som poprosil o krátke vyjadrenie každého jedného z nich k tomu dnešnému špeciálnemu dňu a k tým dátam, ktoré boli odprezentované alebo odprezentované ešte nám budú. A začali sme teda hostiteľmi, teda ak môžem poprosiť pána Korca o ten úvodný prejav.
Môžem? Dobre, ďakujem pekne. Znovu ďakujem a ja vám všetkým, že ste prišli. My považujeme túto konferenciu za historickú. Myslíme si, že sa poprvýkrát podarilo priniesť na jedno stretnutie, na jednu konferenciu zástupcov dvoch európskych organizácií, ktorí prišli z Bruselu kvôli tomuto, našich politikov, bol tu pán minister zdravotníctva, lekárov, pacientské organizácie, zástupcov farmafiriem, takže v podstate všetci tí hlavní hráči tu boli poprvýkrát. A poslaním tejto konferencie má byť poukázať na problém, ktorý tu máme, na problém, ktorý je palčivý a treba ho riešiť, ukázať, aká je situácia dnes a aké sú možné riešenia. Práve preto, že sa nám podarilo zabezpečiť účasť tak širokého spektra hráčov na poli zdravotníctva, veríme, že sa nám aj podarí vyslať správnu správu von, že áno, onkológia je akútny problém, treba to riešiť nie len sľubmi, ale činmi. Ďakujem pekne.
Pán Babela.
Ďakujem veľmi pekne. Takže momentálne ja tu zastupujem akademický sektor, takže som veľmi rád, že aj my sme boli pozvaní a my teda chceme prispieť. Najšťastie ja neliečím, ani sa nestaram potom o tých pacientov, ale chceme dodať to, čo je nesmierne dôležité pre všetkých stakeholderov, vrátane štátu, a to sú dáta. Takže sa veľmi tešíme, že v podstate môžeme aj na tejto aktivite odprezentovať prvýkrát skutočne unikátne dáta z oblasti onkológie, ktoré pevne verím pomôžu nastaveniu budúcich stratégií v oblasti onkológie pre Slovensko, ktorú tak veľmi potrebujeme. A nie len tu, potrebujeme teda aj pre celé zdravotníctvo a podobne. Takže sme radi, že môžeme prispieť. No a mojou snahou skutočne bude reagovať aj na otázky a na koncept a možno, že aj význam všetkých tých čísel, ktoré dneska budeme hovoriť. Myslím si, že to bude veľmi zaujímavé a do budúcna sa tešíme na ďalšiu spoluprácu s Onkoalianciou s tým, že tie dáta sú len začiatok. Pevne verím, že ten koncept a v podstate význam tých dát bude vzrastať s postupom analýz, ktoré budeme spoločne robiť.
Ak môžeme pokračovať pánom Morriseom. Mike Morrissey.
Well, thanks very much. I agree with Stefan that it's a historic moment, certainly for our organisation, because it's the first time that we've come to a national capital to talk to ministers, to talk to parliamentarians, to talk to stakeholders across the piece about cancer inequalities, not only in Slovakia, but across Europe. We're in this once-in-a-generation period called the Europe's Beating Cancer Plan. Once in a generation, we say, because we've been calling for action across European borders for many decades. And now, in recent years, since 2020, we've been developing and now implementing Europe's Beating Cancer Plan. And the reality is that there are inequalities in access to cancer care, cancer treatment all over Europe. It's not one country that is better than another country. oftentimes, even in one city, there is different access to cancer care, treatment, and prevention. So we are calling for attention for this subject and links between what goes on in Brussels in Europe's Beating Cancer Plan and what goes on in national parliaments and in each country, because we think that there are very close links that should be there to make sure that we beat cancer. And the data I was presenting from the European Cancer Pulse was showing for Slovakia, it's a story of good news and bad news. It's a mixed picture, like most countries. Some things are going very well. For example, above average compared to the rest of Europe on screening for colorectal cancer and cervical cancer. Above average, a better program than average on HPV vaccination, vaccinating both boys and girls. So there's some good news in the data that we presented. There's some stuff to improve, but the most important thing we believe is it's a team effort. It's a team effort pulling the data together, and it's a team effort to focus our attention on how we're going to improve things for our citizens, for our cancer patients, for their caregivers, for their loved ones.
Thank you very much. And last but not least, the representatives of YARC, Andre Carvalho.
Hello, everyone. For me, represented here with Clement Chauvin, the International Agency for Research on Cancer, is a pleasure and an honor to be here in Bratislava. And we are here by a request from the Minister of Health from the Slovakian Republic to the European Commission that commissioned us for a project on improving the cancer care coordination in Slovakia. This is mainly about cancer screening and the process and the communication on cancer screening, but this is part of the whole cancer care continuum. So it's a privilege for us and to be here in this event talking about the quality care of cancer patients in the country. Thank you so much.
Thank you. Thank you very much. Just to add to what Andre said, as IARC, as the International Agency for Research on Cancer, not only we are here to work with the Ministry of Health of Slovakia, but it's also very important to be able to listen to what's happening at country level, as well as to share some best practice. IARC believed from the beginning of its creation back in the 60s that cancer cannot be solved by one set of stakeholders or by one country only, and it actually requires international collaboration if we want to do something. And I believe that what we actually witnessed today is the first step for that, that there is a possibility, and thanks to Onco Alliance, to actually bring partners from different perspectives, being from the European Union organization as the CEO, and IARC, that we can actually work together, share experiences, share best knowledge and best practice, so we can actually go forward in the fight against cancer. Thanks a lot.
Thank you very much. A teraz nech sa páči pokojne individuálne rozhovory. Áno, nech sa páči.
Raz, dva, raz, dva. Hello, everybody. I hope the lunch was delicious, that you are well rested. We can continue with our topic. We will talk in this panel about improving cancer care, coordination and screening, and I'm glad to introduce to you my guests, Andre Carvalho. We met you before. Yes. Senior scientist from International Agency for Research on Cancer. Then we have Clément Chauvet, Strategy Resource MOP Officer from International Agency for Research on Cancer. Hi. Thank you for being here. Daniela Kalajová, Public Health Officer from Ministry of Health of Slovak Republic. Welcome again. And Simon Dres, is it right? Policy Officer from European Commission. So, how can data and monitoring systems for screening evaluation in Slovakia be improved? I think that this will be best for Ms. Kalajová. Can we improve the data collection?
This is a very difficult question because we already had a discussion about the data. Data are very well protected in Slovakia, but of course we are trying with our colleagues from IARC to find the ways how we can better use data for program evaluation and monitoring, because there is no program without data and evaluation of data.
So what could we improve? What specifically could we make better?
First of all, we need to have a discussion about the indicators and about the awareness, what kind of indicators we need for evaluation. Then we need to, of course, to change framework of our legislation, because there is no access without legislation improvement. And then we need to pilot collaboration between organizations like National Health Information Center, Ministry of Health, professional societies, and so.
I would assume, please correct me if I'm wrong, that the biggest challenge is that we have a lot of data, but we have to pick which are important. Andre, is that right? Is my presumption right?
Yes. So the data is, you know, when you go to a GP, to a specialist, they are recording medical data. But right now, most of that data is in text. And if you, as you don't have structural data, the solution, as being discussed this morning by Stefan in his project, is trying to figure out an intelligence artificial way to read that text and bring the data. And this is going to be important for all the data that you have so far. But moving the future, you need to have coded data, meaning that your data should be registered in a way that each important event, each important information is a metadata, meaning that is a code, right? We have codes when you have a disease. We have codes when you do a procedure. You need to use those codes in terms of just free text. Once you have that, then we begin to share the data, and then we have the full picture, right? Right now we have some pictures, we don't have the movie, right? And we need to work on that, and the data is fragmented and is in a free text. What at this point, without artificial intelligence, you cannot make a good use of that data.
Yeah, Mr. Chauvet, but the context is important as well, right? We need the movie, the pictures, but we need the screenplay as well. So the context in which we see the indicators are important as well?
Yes, for sure, they're very important, because every country will be different. No, this is also what we are working on as part of IARC. Just to give you an idea that, and Andre will know because he's managing that program, but we have a program called the CanScreen 5, or Cancer Screening in 5 Continents, that allow to collect data from all over the world and to be able to actually compare different countries depending on their context and depending on the methodology they use. So yes, we need to collect the data. We need to collect the right data, as Andre is saying, to make sure that we have we can do meta-analysis of those data. We can compile them and understand exactly what they mean, but then we need to make sure as well that we put them in the right context to make sure that the analysis is the right one. We see them with the right lens.
Simon, so what are the biggest challenges for Slovakia in the data area?
Well, I think the good thing that Slovakia did was ask for technical assistance, and that is what we are providing in this project. And I think what IARC has found in the interviews, in the visits that we have done when we were here last year, really is that one key constraint is the delay in registering cancer cases. Because if we don't have the cancer cases registered in a timely manner, usually, let's say 2 years is acceptable, then we can't really measure the outcomes of any of the policies we were discussing this morning. We can't track success because we don't actually have a means of verification. So this delay in the registration of the cancer cases, that needs to be reduced.
What causes the delay?
Well, that's something we are working with the National Health Information Center to find out, really. So we actually have this week a visit of an expert from Croatia coming to try to identify what can be done in terms of procedural terms to really speed up the process. Because I think we are now at around 10-year delay, 7 to 10-year delay, and we should come down to 2. And a lot of this will probably just be a procedural matter, so just reorganizing how it is currently done. And the other thing is what I made this comment/question about earlier is really about also having a similar registry for the screening program, because to really track people through the system, right? To be able to say who has been invited, who has not shown up, what are maybe also demographic information we have about that person, and how can we better target those at-risk groups that we really want to reach. So I think, as we have heard today, data really is important. Data is power to allow us to then formulate specific policies and new programs to plug all the different gaps where we are losing people.
Okay, so how to target, that would be the main topic now. The state-owned insurance company sent out last year 57,000 invitations for mammography last year. However, less than 3% of women attended the examination. In the end, 210 women had a positive result. So it seems that the biggest problem is human.
Always, huh?
Yeah. So how to, even though you sent out an invitation according to this information, it doesn't really mean that they will come to the mammography. So how to target the groups and how to get them into the procedure.
So a few things there that we need to understand, and Clemana afterwards can talk about communication. So it all becomes to every program that has a high participation, not only send invitation, but recall those that did not come to invitation, right? So you send 30,000, you got to 2,000. What did you do to the other 28,000? Did you send an invitation, a reminder? The system
Is there
now,
any number of the reminders you should send?
People send 2 at least, right? The UK that has a high rate, they say what call recall is that, if you don't show up, I invite you again, right? And once more, and then I invite you the next round that you should come. And that increases participation. The others that how that being sent, right? For example, from other countries that 20% of the letters goes for a wrong address. Is that woman really receiving that? Is that in a language meaning that they understand? What is being requested there? What is the awareness that you're going to receive an invitation? Please look, right? Because we are so used. If this go for a letter. Right, I don't remember last time I opened a letter, that comes that I'm not expecting, and they say this is just pub, even from the government, just telling you what they are doing.
So what, text message?
No, letters.
Letters?
Yes, most of the invitations, because that's what have been working in the Netherlands, in the UK, is paper letters.
But, okay, Does this count for the younger generation as well? You get a letter?
No, but remember, mammography is from 50 to 60. It's 9. So how can you get? And I'm going to give to Clement because, he's the one doing a study on that, in another project, and he's responsible also for that part of communication. But it goes in that, it's kind of the generation that you want, will look for a text message and believe that this is from the government and you should go. So is anybody trying to test? So come on.
No, thanks. Sorry, just to go back perhaps at the beginning. And just one thing, that screening is actually not just a test. It's actually a process. It's a journey, no? You start with the screening, but then you need to identify the target population. And then after that, it's not only the screening, but if ever there is a positive diagnostic, it's the way that you can refer them to treatment, etc. So you need to take that into account. Take also into account that screening is actually to reach out to a large number of people that at that point in time, they believe that they are healthy, so that they don't need any medical kind of encounter neither. So it's very difficult to actually bring someone to an hospital to actually do something for something that they don't believe they need. So it's all the part of prevention and preventive health checkup. So, and the fact is that screening is not neither 100% sure that there is in screening, you can have false positive, false negative. So there is a need to actually make sure that you have a transparent communication, but that you explain exactly what the process is about. That again, it's not just one test, but it's something a bit more than that. It's about prevention, so it's also explaining what could be the benefits of it and the fact that the benefit will far outweigh any kind of risk. But you also need to explain the risk. So that what I mean is that the communication around screening is actually very difficult. It's not something that's simple. It's not like it's not because you break your arm, then you go to the doctor for sure, and there is no problem. You're going to go there, you're going to meet a radiologist, and you're going to get a cast. For screening, it's much different because it happened at a moment in time where you don't believe you're sick. You're afraid to go to screening because you're afraid that you can get an answer that you are in fact sick. So you're going to delay that part as well. So there is a need to bring a lot of health literacy to the population, making sure that people understand why they need to go for screening program, making sure they understand what could be the benefit for them in going there. And that again, it's a way of preventing cancer or actually preventing late-stage diagnostic for sure. And making sure that there is, and again, that this communication happen at different level. I don't believe that it's just sending a letter that's going to actually work. And especially because right now you need to have a communication strategy that's going to be multi-pronged and not only one medium of communication, not one letter, but you can have many others. And it could be through media, it could even be through innovative method like with ambassadors and other, etc. It could be through digital, and it should be through digital media as well. So it should be a combination of it, and also a combination of different stakeholders bringing that communication. It's not only, it should mostly could be handled by the state, but also that the GP will have, the general practitioner will have a big importance in that, the insurance company and other, etc. So we need to map all that. And this is what we're doing right now with the ministry, to try to map all the stakeholders to understand the barrier and the perception of the population in Slovakia, to make sure that at the end we can create the right strategy that will answer to the context.
Ms. Kaleva, recently I saw a report on TV Markiza stating that women in some parts of Slovakia are waiting so long, for example, for breast ultrasounds, that they are being given appointments for the year 2024. So it's difficult to expect women to attend screenings if they wait for months and months. So isn't this a problem we should address as well if we are talking about the screenings?
First of all, I would like to highlight that ultrasound for women is not an evidence-based approach when we are talking about the screening. It's only mammography in certain ages, and that's why we decided to have a network of evaluated mammography screenings centers. We already have 21 in Slovakia. Of course, we are not in the end. What is the main principle of evaluated screening mammography center is that there is a request for high quality of management of the women in. That also means that there is a need to have a very short terms for the when we are talking about the process of the screening. So the aim of the ministry is to develop a network of evaluated mammography screening centers, which will be also in high quality.
Mm-hmm.
So what you are asking for, it's an individual case maybe, and as you know, the system, how it's organized in Slovakia, it's not a state-based system. It's also private-based. So we are not able to manage every woman in Slovakia. But when we are talking about the organized screening, there is an aim to increase the number of evaluated mammography screening centers.
Simon, is this one of the barriers, the lack of doctors and sisters, which we are experiencing in Slovakia? And it will be even worse because the whole Europe is experiencing lack of doctors. So is one of the biggest barriers shortage of human resources in the system?
So I must say I don't have the numbers for oncology workforce off the top of my head, but I mean, as you said, it's an issue across all of Europe, and I think with the pandemic we have seen that a lot of people have also just quit the profession, right, because of the working conditions, because of the extra pressure, because of the feel that there was not enough recognition of the work that was being done. And then, of course, we have all these demographic shifts. So, I mean, a lot of the GP workforce is aging. We have people leaving to other countries. So I think almost every European Union member state has this issue with the workforce. We have projects, just to give you an example, in Latvia and in Ireland exactly on this, because even on the government level, sometimes we don't have enough data really on the healthcare professions, and we cannot really reliably model the workforce and make forecasts that also take into account future shifts. So, I mean, just to give you the example of Ireland, for example, they have done demographic projections that people will move, relatively speaking, to the other side of the island. Not people literally moving, but people on the one side are aging and the population is declining. There's a population increase on the other side, and over the next 20 years, that will mean that they will need more hospitals. So you need to incorporate all of these factors as well into your planning and then adjust the training pipeline accordingly. So I think here we have to do the same. I don't know, Andre, do we have more information on the workforce that we can speak about here on oncology specifically?
So far at this moment, no. We know that we need more accredited centers for mammography, right? That 21 is not enough to provide all the mammographies needed for a population-based screening. We know that colposcopy is an issue in terms of a lack, but we kind of, as we're mapping now, right, then we're going to begin to understand and roadmap what we need to increase in terms of workforce and infrastructure, right? So it's a mix, right? You need to have.
I think maybe to add on that, and that's a general point that doesn't even have anything to do with cancer specifically. What I always am surprised by is that people don't realize that when we talk about the workforce, this is nothing that we can do in the short term, really, right? So we can't just plug doctors from the tree. So first of all, the people don't exist, and then even if we increase training numbers in medical universities, we are looking at 10 to 15-year time horizons until we have trained specialists. So if we have a challenge in the next 2 or 3 or 4 or 5 years, then the only thing we can do is shift tasks to other professions, so change the skill mix in the workforce so that other people do other tasks. So we talked this morning about the nurses having more roles and more tasks. I mean, obviously, we also have shortage of nurses, so we have to be creative. Huh? But, you know, I sometimes go to member states, I will not say which one, and then I ask, okay, so you're creating a new profession for the care pathway coordinator, for a new person that will, accompany the patient across the whole pathway. And then I ask, so who are these care coordinators? And then people say, yeah, it's nurses. They do a training, they go out of the nursing profession, then they become care coordinators. Yeah, but you have a nursing shortage to start with. So, you know, you have to think through where are we displacing personnel and what can we do in terms of procedural innovation, in terms of automation, in terms of reducing bureaucratic workload, because those are the things that we can do short term in the next 2 or 3 years. We can't just magically increase the medical workforce in the short term. So we have to think outside of this box as well.
Yeah, well, now I have a gender feminist question. So according to the data we saw today, maybe it's a naive question, but according to the data, we are in Slovakia worse in prevention against cervical cancer of women and breast cancer of women. Are women less aware of the healthcare in Slovakia? Are they burdened with workforce and they cannot make it to the doctors? Why is it that women are suffering more of these consequences we are talking about today? Do you have any answer? Or is this a out of context question? Is this a bad data question? Please clear that up for me, somebody.
Usually what we know from published data that women are more responsible when we are talking about the preventive checkups than men. It is a general problem with health literacy among our population. So I don't want to ask if women have a special problem. The problem is in general, we need to increase public awareness about the prevention. And of course, there is a lot of components that are barriers when we are talking about the preventive checkups or screening attendance or even vaccination coverage in Slovakia. For example, WHO has a flagship initiative now, Behavioral and Cultural Insight, which aim to find out maybe some answers to similar questions, as you said. We don't know all the answers. We need to find the answers how to improve better implementation of our activities. It's not enough to say people. It's not enough to have a discussion about the problem. There is a need to make intervention in environment somehow. The main barrier could be your environment, your family, your school, your employer, your situation, life situation. So there is a lot of what we can improve. It's not only health information.
Andre?
Yeah, just continue following up, Danielle. I don't think it's a gender issue. It's a health system in terms of, the cancer screening programs in Slovakia is performing low in terms of participation. And those are breast cancer, cervical cancer, and colorectal. But if you go for the colorectal, it's low, but you have more women than men participating, but it's very low overall. So you have a low participation in those programs, and that's what we're trying to change, right? I think it's the screening programs that need to increase more than a gendered issue.
So if we talk about the cervical cancer, the primary prevention is HPV vaccination, right? So we have a gap year where you can get vaccinated when you're from the age of 13 to 14. What are the main areas where Slovakia needs to improve? Why aren't all the children getting the vaccine? Do we have any data for that? Why aren't they participating more?
I don't understand really your question.
Why do we have low rates of the vaccination of the HPV? How should we improve
in general?
Yes.
Okay. It's because low awareness. Like it is not obligatory vaccination. We have very good rates when we are talking about the obligatory vaccination.
Should it be obligatory?
From the expert point of view, should. But from the political point of view, it is very difficult topic for discussion. So prevention, when we are talking about HPV vaccination, is the best in certain age because of the
sexual activity.
Yes, and the history and the immunological aspects. But we are still not there with the health awareness among the parents because we are talking about the children in age 11, 12. So the role, very important, is the role of parents. And the school environment for the future, I think, is the right place for the interventions when we are talking about the increasing the HPV vaccination coverage.
One important thing that's a new information come from the WHO that now is enough to give a single dose of HPV vaccine. And I think this will change the coverage because every count happens that the completion, when it was 3 doses, was kind of, you could get over 80% for the first dose, around 60% of those girls go for the second dose, and then it would be down to 50% with the 3 doses. Then became the evidence that 2 doses is enough, but still, you cannot increase the 67%. Countries that have 1 dose at 90 goes to 70. It's 80, you have 20%. But first dose is always higher, right? And now with the evidence that 1 dose is enough, you can do a huge campaign once a year and get as much as teenagers vaccinated. And I guess these will change because the mass campaign never worked because you had to do the second dose. So you do as a routine, going to the schools and so on. And I think this is going to be a game changer and also facilitate the awareness for the population.
I fully agree with what Andrew and Daniela are saying. I still believe that there is a need for a lot of health literacy. And especially in the times after COVID, there is quite a lot of reluctance from the population regarding vaccine everywhere anyway. We need to understand why, perhaps a bit better, and we need to communicate perhaps a bit better also about what are the benefits and the effect of the vaccine. And that requires not only a mass immunization campaign, but as well a mass communication campaign that clearly explain how people will benefit from that vaccine.
What about vaccination of adult women and men? For example, I have several women friends that got diagnosed with the first stage of HPV virus, and then they got the surgery, and then they had to pay for the vaccine after the surgery, and it was quite expensive. It was like 150 euros or something like that. So shouldn't it be covered for adult women that get diagnosed with the HPV virus? Why are you smiling, Andre?
They should not take vaccine.
Okay.
They should
because
not.
They were advised to take it. I was talking to them.
That was my smile.
Oh, okay.
The evidence showed that once you have the infection, right, because this is not a therapeutic vaccine. This is a prophylactic vaccine. It's to prevent you to get the virus. Once you have the virus.
So we have to educate the doctors as well?
That was my smile.
Okay. So, do we have any questions from the audience? We have the microphone.
About the HPV vaccination, I think there are two problems. Definitely we would welcome the one shot, but unless it's approved indication by EU, we really can't promote one dose of vaccination because then it's off-label use. So one is going to be in the summary of product characteristics, that would be great. And the other thing is that unfortunately we only have 1 year when we can vaccinate the girls and the boys, and that needs to be extended. And if it's not extended, then the uptake will be still very low because many either pediatricians or parents miss it.
I agree. You know, all the countries say are going to vaccinate all the girls in that school year, right? Regardless of what age they have in that range. There is at least 2 cohorts that miss that because they were not in school during COVID, right? And we need to figure out exactly what you said, how we go after that cohort that miss vaccination and how we expand. It's still the best strategy thinking about overall is going to 1 year of the school, but more and more countries, because of COVID, is doing a catch-up in the community health centers or somewhere that those girls inside that age range, if they miss the vaccination, they can still get. So and that might be a strategy. I understand the recommendation from WHO is quite new, just came December, January, and it take a while for EU to have approach. But Australia already changed this, UK already changed. In Latin America, there is at least 3 or 4 countries that change. So even countries that would have enough funding or budget to continue with 2 doses are changing because, you increase coverage. It's easier to deliver and you have the same efficacy of the treatment. But I understand EU, there's a procedure that it needs to be approved in another level. Some countries just can go with the WHO recommendation, change right away because, they have a decision that's a single country.
Any other questions from the audience?
It's not a question, it's a comment. You said the parents have to educate their children, but you have the vice versa case. There was a kind of a private initiative in Latvia, an IT, medical IT company launched a campaign for against breast cancer. And and it was so modern technology, and girls came very quickly and brought their mothers. So there are now different, I suppose that's what Clément is dealing with. There are new approaches that can be dealt with, and so the young generation may be more efficient. I don't know. This is up to.
Would this be a way how to do it?
I believe it could be very interesting actually, because the children, they can become prescriptors, no? They will actually try to motivate their parents to actually go for the program. So it's something that could be looked into, and they might have a completely different perspective about. And for them, the idea of prevention actually might sound perhaps a bit more concrete than it is for their parents. For their parents, still something far away. It's for them, it's the idea of losing their parents, which is something that they can't accept. So yeah, it could be something very interesting actually.
Yeah. I know several teenagers that wanted to get the COVID vaccine and they didn't get the approval of the parents. So maybe the younger generation is more smart about the vaccine, of course. Any other questions? Yeah?
So thank you so much. My name is Vladimir Balázs. I am onco-urologist and politics too. My question is, why do you think that this is a political problem, this type of vaccination? I really don't understand very good.
Well, maybe it's a question for you, as you are the member of the parliament.
But I don't see the problem. You see it.
Do you think it's feasible for politicians to agree to get HPV vaccination in obligatory routine scheme in Slovakia? Yes. You said you are a politician, so my question is, do you think it is feasible for the future to have it in routine vaccination scheme? Yeah, that's why I said it's a political issue.
You just find the champion.
Great, thank you.
Well, but Mr. Balázs was in the governing party, so...
I'm being serious, right? We need champions. We need someone that's going to take that to the others, right, and promote that. Thank you. We need ambition.
Well, do you want to add something? Okay.
If I may make a comment, because I think we have a lot of experience with HPV vaccination across all the world, and we have seen a lot of behaviors. And when it comes our position as a company, and this is something that we are promoting everywhere, when it comes to vaccination, we feel that it is important for people to understand what the vaccination is, to have the scientific community on board and explain to the population what are the benefits of the vaccination, what are the risks, and to have a conversation rather than impose vaccination on people. So what we have seen working best is when key stakeholders come together and decide to a very specific plan of action in order to bring VCRs up. So in that sense, I don't know if it is a political discussion or not, but I think imposing perhaps vaccination, it's not necessarily what we need now. I think it's better to really discuss about the benefits of vaccination in general.
Yeah, but it's a longer path, right, than the...
I think Slovakia has done great advances, especially when it comes to HPV. We were discussing earlier that it's one of the key examples in Europe in terms of catching up. Of course, there is still a lot of room for improvement, but I think the important thing is that the ministry has a very clear plan in terms of what they want to achieve and which direction they want to take. And with a consistent implementation of this plan, I think we will see very fast uptake of the vaccination. So, well done.
Thank you. Well, Simon, we were talking before the panel discussion that you are experiencing the second Minister of Health and you were third one? Yeah, in what, 12 months? So maybe that's the political issue, why, right? Is it that we have too many ministers of health in a short period of time.
Well, I will give you a commission response, right? I mean, obviously, it's not our business to, have opinions about national member state policies. But I think what is relevant for our project here is that I think we will conclude sometime in the fall with this project that IARC is delivering here, and then I think it will be up to the minister was here, but then it will be up to whoever is the new minister, of course, to go forward. And I think we will be very happy to come back here and to communicate what we have found and the recommendations. And then, of course, it's up to the member state to change national health policy. So, but we are happy to help.
I'll be provocative here, right?
Please.
I think the change, we cannot control the change, the frequent change of the ministers, right? We can see that instead of a threat as an opportunity. He's leaving. Maybe he can accelerate some changes that we need. That's not, organizational or, funding changes, but we need a few things that accelerate the pace of implementing, nominating people in charge of something. And this is something that any minister can do at any time, even who is leaving the office.
Even Mr. Palkovic.
So let's try to see this as an opportunity to ask for a few things that he can sign, he can promote as his duties until he leaves the office. He'll not sign anything promoting, or promising millions of dollars for the program because he cannot. But there are things that we can take advantage. He's a technical person, and if he wants to promote a few things, I think there's opportunities there.
One more question from the audience.
Thank you. Just a quick question on behavioral approaches, because I can imagine that's a thing in screening, and I wonder what's your take on that, because it touches also on the discussion that we had a couple of minutes ago in terms of people understanding reasons for screening. If I'm not mistaken, there's data related to. So just to give an example, if you use default bias, so you send a patient a letter saying come to an appointment on a particular day, you're going to have your whatever colorectal cancer screening done that day. You work with the default. There seems to be a link between behavioral approaches and a lowered bar in terms of understanding why to go for screening. So in terms of, I wonder what's your take on the balance, whether to use behavioral approaches in order to get people to show up for screening and boost the numbers that are quite low in Slovakia to begin with, and how you see the connection between that and sort of getting people to actually understand why it's important to go for screening. Thank you.
It's a very important question, and behavior science is actually very needed to make sure that you can bring people to actually buy in and to actually participate in screening program. So that you need to bring people along a certain journey. At the beginning, they are completely unaware about what the program is about. So first, to provide them with information, so actually they know that the program exists. But then they would be undecided about if they want to participate or not. And then you need to actually make sure that they can make that informed decision by themselves. The idea, again, of the screening that, and again, to link back perhaps to vaccination, but for sure screening, it should not be mandatory. It cannot be made mandatory, and especially because it's not a 100% sure program. You never know. You will have false positive or false negative along the way. So the decision remains with the person. So for sure you will trigger, if you want that person to make an informed decision about their participation into a screening program, you need to use behavior science to actually understand what will trigger them, what's not, the way they will understand the message. You need to make sure that the message will be simple, transparent, that it will be according as well to different level of understanding. You can't expect people to understand, it should be kind of layered. You can't expect people to understand very complex issue or complex problem at first. You need to bring them there. So you need to, it's really something for me, it's really a journey, and you need to bring people along the way, and at the end, not forcing them to make a decision, but allowing them to be empowered so they can make that decision. And this is where behavioral science will work, because you need to understand clearly the way that they will think and what will actually trigger a decision for them or not. So it's actually definitely very, very important and kind of a cornerstone of it. Hope that answered the question.
One more question, and then we have to end the discussion, okay?
As we are supposed to look for champions, are there champions that really know how to convince the hard-to-reach populations? And with hard-to-reach populations, I mean those that are skeptic or are in complete denial. So in Germany, there were, I don't know, something like 20% who denied the benefit of COVID vaccination. Is there any chance at all? Should we invest in that? Because usually those are, at least for lung cancer, those that are probably the highest risk, and what would be good strategies for that?
Maybe we should pay to the disinformation websites, you know, to promote the vaccination. That would be...
Yeah, that's another call, yeah, definitely. I would say that for me that there is a proverb in France that we say that you should not mettre la charrue avant les bœufs, is that you should first try to strengthen for me the program first, and then go for the last mile, no? But not try to go for the last mile if the program is actually not strengthened. And actually, when I'm in the program, it's not only in terms of communication, but also in terms of data and processes and others. So trying to make sure that you have a solid kind of a program. Trying to make sure that as well you have the buy-in from the majority of the population for the program, that there is a consistent, coherent kind of a health literacy awareness among the population, that people understand why, etc. And then when you have that, when you have all that secure, then go for the last mile. But if you start going for the last mile at first, I do believe it can bring some kind of a, it can be a bit damaging, no? Because your program won't be strong enough. Then after that, it can bring some dissonant voices within the program that at the end can be contagious and can also bring others to actually reject the program itself. You see what I mean? So I will strengthen it first, and then I'll go for the last 20%, not the other way around. But the 20% are very important for sure, but do things in order instead of trying to jump into the conclusion.
Yeah. It's more than 20 in Slovakia, unfortunately. Thank you very much. Thank you very much, Andrej Carvalho, Senior Scientist from International Agency for Research on Cancer. Thank you, Clément Chauvet, Strategy Resource MOB Officer from International Agency for Research on Cancer, Daniela Kalajová, Public Health Officer from Ministry of Health of Slovak Republic, and Simon Dres, Policy Officer from European Commission. Thank you very much for an interesting debate. And now we head into the last panel. Thank you very much. The last panel will be in Slovak, I think, so please now is the time to get the headset if you don't speak any Slovak. Yeah. Please. So first we start with presentation of Robert Babela, former State Secretary of Ministry of Health of Slovak Republic and a health expert, and he will talk about how much does cancer cost us. Dobrý deň, pán Babela. Áno, už začíname. Môžete sa postaviť. Please take the headset and come back if you are interested in this debate. And then we can start. Let me repeat that the languages are on channel 1 and 4. I think 1 is Slovak and 4 is English. No? Other. 1 is English and 4 is Slovak.
No dobre, zdá sa, že tá predchádzajúca skupina, tak ste ju teda unavili, že všetci radšej odišli. Ale vy, ktorým teda máte záujem o dáta, tak vedzte, že dneska budete vidieť prvé v podstate dáta svojho typu a analýzy vôbec na Slovensku. A som rád teda, že môžeme práve v spolupráci s pacientami, s Onkoalianciou, že sme mohli teda participovať a pripraviť niečo podobné, od čoho sa pevne verím, budeme vedieť do budúcna odpichnúť ďalej. Čiže podarilo sa nám za relatívne veľmi krátku dobu, ešte cez víkend sme to teda finalizovali, dať dokopy nákladové dáta za 8 skupín onkologických ochorení na Slovensku. Vybrali sme teda také, že najvážnejšie a najčastejšie. Môžete ich tu vidieť, že od C15 až do C96, kde je rakovina krvi. A čo nás zaujímalo, principiálne boli dva typy dát, alebo dva typy údajov. Prvý typ sú náklady zdravotných poisťovní na Slovensku na tieto diagnózy a druhý typ dát sociálna poisťovňa. Čiže principiálne to, čo nás to stojí z nášho vrecka, všetci prispievame môžeme to kľudne nazvať daň, zdravotnú, sociálnu, čiže koľko peňazí ide z tých našich peňazí práve do onkológie. Čo sa týka priamých nákladov zdravotných poisťovní, tam sme sa pozerali na ambulantnú sféru, ústavnú sféru, potom lieky, ešte tam boli medical devices, čiže zdravotnícke pomôcky, diabetologické prípravky a doprava. A čo sa týka nákladov sociálnej poisťovne, tak principiálne nás zaujímalo hlavne invalidita a PN-ky. Takže poďme sa pozrieť najprv na to, ako vyzerá epidemiológia. Musím vám povedať, že nikto na Slovensku momentálne nevie, koľko máme pacientov s rakovinou. Čiže vieme len incidenciu a nikto nevie prevalenciu. Čiže bohužiaľ tu vám neviem ani ja ukázať. Ale čo sa týka nových prípadov, tak v princípe za 5 rokov, ktoré sme sledovali, 22 až 2018, nám pribudlo 134 000 nových prípadov onkologických ochorení len pre týchto 8 skupín, čo znamená jedny Košice. Hej. Áno, samozrejme môžeme sa baviť o tom, že či niekto nezomrel a tak ďalej, ale principiálne, keď sa pozrieme čisto na tieto dáta, tak sú to jedny Košice za 5 rokov. Priemerne nám pribúda asi 34 000 nových prípadov v podstate onkologických ochorení na tento set 8 skupín onkologických ochorení. Najväčší skokan 2021 versus 2018 je diagnóza C60, to sú zubné nádory mužských pohlavných orgánov, čiže tam bol naraz plus 10%. A najväčší pokles zaznamenali v podstate pri onkologických ochoreniach, to sú zubné nádory močovej sústavy minus 11%. Čiže to som vybral len tie topky z pohľadu nárastu, z pohľadu poklesu. Čo sa týka nákladov, týchto 8 skupín onkologických ochorení nás za posledných 5 rokov stálo 2 miliardy eur. Čiže posunuli sme sa niekde v roku 2018 od 370 miliónov a dostali sme sa až teda po 480 miliónov eur v roku 2022. Z logických dôvodov, vzhľadom na to, že je 23, nikto tieto dáta nemá, takže budeme radi, keď zase pozrieme aj 23 a uvidíme teda, ako ten trend pokračuje. Nárast 2022 versus 2018 bol 105 miliónov eur na všetky tieto diagnózy, ktoré sme teda hodnotili dokopy. No a pozrime sa teda, ako to vyzeralo na jednotlivé časti starostlivosti o onkologických pacientov na týchto 8 segmentov onkologických diagnóz. Najväčšiu časť alebo najviac peňazí nám ide do ambulantnej starostlivosti. Dokopy za 5 rokov 810 miliónov eur. Tu v podstate bol nárast v rok 2022, 2018 asi 67 miliónov eur. Čiže diagnostika, ambulantná starostlivosť, dá sa, že na ňu momentálne vynakladáme najviac peňazí. Na druhom mieste, asi úplne logicky, ústavná zdravotná starostlivosť 600 miliónov. Hej, tam sme narastli len minimálne. Na túto časť zdravotnej starostlivosti sa za 5 rokov ten posledný a ten prvý sledovaný vydalo 6 miliónov navyše. Na treťom mieste, asi tiež úplne logicky, sú lieky. 565 miliónov eur za 5 rokov a ten nárast bodaj by bol väčší, lebo by sme ho tam chceli vidieť, bol 30 miliónov, čiže versus 2018 a 2022, čiže porovnanie týchto dvoch rokov. Či je to veľa alebo málo, môžeme potom diskutovať. Ja si myslím, že to je strašne málo a poukazuje to aj na skutočne priepastný rozdiel v dostupnosti inovácií, ktoré tu máme v porovnaní so západnou Európou. Čo sa týka zdravotníckych pomôcok, to sú už oblasti, ktoré sú menej zaujímavé, 65 miliónov, minimálny nárast, teda pokles dokonca 200 000. Dietetické potraviny, ktoré sú predpisované lekárom, 12,3 milióna, tam je tiež minimálny posun. A na dopravu sme vynakladali za posledných 5 rokov asi 25 miliónov. Čiže v podstate toto je 5 základných skupín, ktoré sme zanalizovali a ktoré teda chceme zanalizovať aj ďalej. No a čo sa týka sociálnej poisťovne, tak na PN-ky v podstate sa vynaložilo za 5 rokov 144 miliónov eur. Je tam nárast o 5,6 milióna eur 2022 versus 2018 a tu je ešte teda rozbité medzi mužov a ženy, len aby ste videli, v podstate gro péniek ide, alebo sa predpisuje ženám. Tu má takú lídrovskú pozíciu, bohužiaľ, diagnóza C50, čiže rakovina prsníka. Čiže ten rozdiel, alebo ten pomer je 36% muži, 64% ženy za posledných 5 rokov. Ja som v podstate dával aj taký status na LinkedIn, ešte keď sme mali preliminary data, hneď sa mi ozvala Mirka Feveneš, ktorá v podstate otvorila túto tému a pevne verím, že sa budeme baviť o PNK a tomuto spôsobu sociálnej pomoci aj ďalej, že to rozbijeme na drobné. No a druhá časť je invalidita, ktorá v princípe tiež rastie, je niekde na úrovni 64 miliónov eur a narastlo nám 2022 versus 2018 o 2,5 milióna eur. Takže toto sú de facto prvé dáta svojho druhu vôbec na Slovensku, ktoré sa nám podarilo teda dať takto dokopy. V tomto prípade opäť viac invalidít je uznaných ženám v pomere 60% versus 40% muži. Takže na záver, možno, že len krátke zhrnutie. Priame náklady, tak ako som spomínal, za 5 rokov na 8 klástrov onkologických ochorení cca 2 miliardy eur, čiže to sú tie najvážnejšie, najčastejšie onkologické ochorenia na Slovensku. Priame náklady dokopy nám rástli necelých 30% v porovnaní 2022 versus 2018. Najviac nám ale rastie ambulantná starostlivosť takmer o 50% za 5 rokov. Ešte raz, 53% za 5 rokov nám narastli náklady na ambulantnú starostlivosť. Len na týchto 8 skupín onkologických ochorení. Lieky 30%. 2022 versus 2018. Čo sa týka nepriamých nákladov, je to oblasť, možno, že viacerí viete, ktorá mňa teda veľmi zaujíma, vzhľadom na to, že mi ide o pohľad na ochorenia komplexný, to znamená, že chcem vedieť, koľko to stojí všetkých placov. Tam sa pohybujeme na náraste asi 22%. Otázka je, že my samozrejme budeme robiť aj predikcie do budúcna, že kam sa budeme takýmto tempom šplhať, ale skutočne, keď si zoberieme minimálne do roku 2030, tak určite nemáme na to, aby sme si toto dovolili ďalej nejakým spôsobom takto niesť. Nebudeme zvládať tieto náklady, určite nie takýmto tempom. Za mňa teda, ja si myslím, že tam už nemám všetko, asi všetko. Teraz nemám tam už nič a za mňa všetko. Takže ďakujem veľmi pekne.
Ďakujeme veľmi pekne. Pán Babela si sadne aj k nám do panelu, ak som to správne pochopila však. Je to tak? Dobre. Teraz mi dovolte privítať aj ďalších hostí, okrem teda Roberta Babelu, ktorý sa k nám pripojil. Je tu aj Patrik Herman, ktorý je teda člen Onkoaliancie, teda bordu Onkoaliancie. Dobrý deň. Europoslankyňa Lucia Ďuriš-Nikolsonová. Dobrý deň. Eva Kováčová, ktorá je z Ligy, ako sa to povie po slovensky, lebo mám to tu len po anglicky, proti rakovine. Ďakujem veľmi pekne. Vy ste teda šéfka, je tu aj Penila Gunther? How do you pronounce it? Gunther. Okay. Board member of Mission on Cancer, European Commission, and member of National and European Parliamentarians for Cancer Action. Thank you for being here. Tak, poďme rovno na to. Začneme tak pacientsky, lebo to je dnes naša téma. Čo vnímajú onkopacienti ako najväčší problém?
Dobrý deň, prajem. Ja skôr ako sa vyjadrím k tejto otázke, naozaj mi nedá nedotknúť sa tej predošlej témy, aspoň pár vetami. Hovorilo sa o prevencii a vlastne aj táto prezentácia poukazovala na nelichotivý vývoj nákladov. A ja sa jej chcem dotknúť preto, lebo momentálne 2 mesiace kontinuálne chodíme 3 dní do týždňa od rána do večera po mestách Slovenska naprieč Slovenskom s prevenčným stánkom a hovoríme ľuďom o prevencii, prečo je dôležitá, kedy na akú prevenciu majú chodiť. A je to naozaj mravčia, náročná práca.
A čo sa najviac boja, keď sa s nimi rozprávate?
Prvá a najčastejšia odpoveď, bojím sa, že mi niečo nájdu, preto nejdem. To je v zásade vždy veľmi časté. Potom ich rozčulujú dlhé čakacie lehoty. Povedzme si, že tá skupina, ktorá chce chodiť, nechce tak dlho čakať. A potom sa obávajú toho výsledku, ktorý im povedia. A žiaľ, častokrát zaznieva, lekár na nás nemá čas a nevysvetlí nám to. Ak sa niečo deje. Takže preto hovorím, že hovoríme o dlhej, ale asi jedinej ceste, ako tieto nelichotivé náklady do budúcna, ktoré si nemôžeme dovoliť znížiť.
Tak, ďakujeme, že robíte túto mravenčiu prácu. Je to záslužná vec. No a teraz poďme k tomu, že čo onkologickí pacienti, ktorí už sú diagnostikovaní, vnímajú ako najväčšie problémy.
Pozrela som si ostatné otázky v našej onkoporadni. Je to spôsob, akým sa respektíve priestor, ktorý dávame pacientom na to, že to, čo im nevie a nedokáže v rámci svojho času zodpovedať lekár v ambulancii, tak sa môžu obrátiť na našu bezplatnú onkoporadňu, kde im je 20 odborníkov k dispozícii. A tie najčastejšie ostatné otázky spočívajú v tom, alebo sťažnosti, neviem, ako to správne pomenovať, povedia mi, že mám onkologickú diagnózu, ale nikto sa mi nevenuje a nevysvetlí mi nič podrobné. Preto ja chápem, že všetci chápeme, že lekári sú preťažení, je ich málo a nemajú čas, ale toto pokladáme za základný problém, ktorý je, že potom pacient si všetko možné googlí, hľadá, rozčuluje tým, zničí tým seba a rozčuluje tým lekára, ale naozaj tá komunikácia s pacientom je kľúčová, ktorú pociťujeme ako problém.
Patrik, vidíte to rovnako?
Áno, v tomto máme na tieto veci rovnaký názor, pretože sa vlastne staráme a snažíme sa pomáhať tej istej skupine pacientov. A keď by sme jednou vetou možno okomentovali práve tú prevenciu, no to je možno alfa a omega toho všetkého, v čom sa potom táto krajina jednoducho nachádza. My tú prevenciu stále nemáme zvládnutú, my tú prevenciu sem tam sa objaví. My sa na Slovensku vždy tešíme z takých krásnych maličkostí, ale to sú stále len maličkosti. A porovnávame sa s tou vyspelou západnou Európou a niekedy nám uniká, že západná Európa je už aj Česká republika a už aj tam nám ušiel vlak tej Českej republiky. Prevencia, ja si pamätám, mali sme politické garnitúry, kde dokázali z jedného týždňa na týždeň zaviesť populisticky 1 hodinu dejepisu týždenne do učebných plánov, bez všetkého, ale aby sme stanovili 1 hodinu onkológie alebo onkologickej výchovy ako takej do učebných plánov, napríklad na základných školách, tak to akože čakáme už 20 rokov. Rozprávame sa a v tom sa zhodujeme, že my už musíme vzdelávať. My máme nevzdelanú dospelú verejnosť. V podstate tú staršiu generáciu, tá, ktorá nám dorastá, a aj mladých ľudí. A keď my nebudeme, ani tých mladých ľudí nezachytíme, v tých otázkach informovanosti, otázkach prevencie, tak nám zase dorastá táto generácia a my nemáme vôbec podchytenú. My učíme teraz, podobne ako aj Evka so svojou organizáciou, učíme dospelú verejnosť na námestiach, vo fabrikách, ako robiť samovyšetrenie prsníkov. What? To by náhodou už nemali sa učiť decká na základných školách, nemali by to už mať takéto veci jednoducho zvládnuté. To už nemajú učiť gynekológovia, majú to mať už v podstate v rámci toho všetko. Ako to, že my takéto základné veci na Slovensku ešte nemáme zvládnuté. No a potom k samotnému pacientovi. Jedna vec je teda otázka prevencie, v ktorej teda štát katastrofálne zlyháva. Tie politické elity to nikdy nemali nejakým spôsobom, vždy to mali v tých svojich programoch ako prioritu. Hej? Ale nejako tie reálne skutky, buď sme urobili iba krátke kroky. Ak sa objavil niekto príčetný, nemá šancu dokončiť svoju misiu, tak my sa tak na Slovensku tak sa v tom tak nimráme a stále to nejako posúvame a tešíme sa z maličkosti. Potom pacient, keď ochorie, stráca sa v systéme. Jednoducho dezorientovaný pacient, poprvé vystavený tomu obrovskému psychickému tlaku v rodine, na pracovisku a on nevie, kam sa má jednoducho obrátiť. Hej, pokročili sme možno v niektorých otázkach tej dostupnosti aj prevencie, povedzme nejaké tej diagnostiky, ale stále to nie je to, čo by sme si predstavali. Ja pracujem v televízii, pracujem tam 25 rokov. Z toho 20 rokov pracujem pre relácie, ktorých sa na nás obracajú ľudia so svojimi problémami a starosťami. Ale za tých 20 rokov sa nezmenil ani obsah tých žiadostí o pomoc onkologických pacientov a ani ich rozsah a počet. Je to stále to isté. Kedy sa na nás pacienti obracajú s tým, že kam máme ísť, máme si zohnať lekára, nevieme, na koho sa obrátiť. To sú stále, nemáme dostupnú liečbu, nemôžeme si ju dovoliť, tú liečbu. Je v susednej krajine dostupná a u nás na Slovensku nie je. My sme sa o tom raz rozprávali. Pacient slovenský občan druhej kategórie v rámci Európskej únie. A keď už sa dostaneme k tomu lieku, na všetky možné výnimky, a to by ste sa čudovali, ako lekári nám píšu, nie že pacienti, lekári nám píšu, A prosím vás pekne, urobte reportáž o tomto pacientovi, chcem ho zachrániť. Ja už som napísal na poisťovne 150 žiadostí, aby som dostala pre neho ten liek a ten liek nedostane. A keď ho už konečne dostanete, to už je ďalšia tortúra. Za čo? Ako si ho môžem dovoliť? Predávajú domy, predávajú autá. Ale to nie sú také, že ojedinelé prípady, že si poviete, že akože raz za čas sa niečo objaví. To je v podstate vyslovene sa s tým stretávame stále a to sa jednoducho napríklad nezmenilo. To znamená, aj ten management pacienta, dostupná liečba, tie dáta ste si tu hovorili celé dopoludne, teraz niečo hovoril Robert a tak ďalej, že koľko máme, aká je dostupnosť tej liečby u nás a v zahraničí. Nie je to tak trošku tragédia a stále to nevieme niekam posunúť a stále nám ten vlak uchádza viac.
Tak položím o chvíľku aj politickú otázku, but Penila, let me switch to English for a bit. So Patrick just said that the patient from Slovakia is a second-class citizen in the EU. Do you think so?
No, I think...
Please, can you take the microphone? Thank you.
Sorry.
Thank you.
I think you should see the Europe's Beating Cancer Plan as an agreement between the EU Commission and the member states to really be a help for the member states to accomplish some kind of common cancer treatment. Because I think one of the most important goals is an overarching goals is to reduce inequalities. So if we can help each other to really achieve, accessibility to new treatments or to set goals, as we heard here earlier today, about scanning or whatever is needed in that particular country, I think you should really see it as a help to connect with other people, research and patient organizations together can also be a very good help for patients in their own country. And I believe in networking in all kind of occasions. And I think just today we can see a very good networking opportunity to learn from each other. And if we don't learn, we can never achieve any goals. And to see good examples from other countries, it's really, I think it should be something that you should reach for, and not to see that, okay, we're so bad in this and that, but to see, okay, if they can do it, we can do it, but we need to do it together, the different stakeholders. And as I said before, I'm a former member of parliament myself and have not been in politics now for some years, but I know the game. And I know how to approach politicians and stakeholders of all kind. And I would say that sometimes, and I'm now a bit provocative, maybe, but I think you need to understand that some politicians and some stakeholders in politics and government, they have so many things around them. So if you have, several meetings during the day, and you should deal with healthcare, you should deal with something from agriculture, or you should deal with this and that. And you don't know really what these people would like to approach you with. I mean, it's not clear, and it's too much details often, and too medical, actually. So I think health literacy, as we have heard about here today, of all kinds, is also something in the EU's Beating Cancer Plan. Understanding is one of the major goals, and understanding is not only about research to understand the causes of cancer. It's also understanding and health literacy for all. To understand cancer and how to approach the people who have the power to really change the possibilities, for example, the Slovakian people, I think that's really something to work with.
Indeed. Thank you for the input. Tak poďme teraz aj k tej politike. Pani Nikolsonová, tak idem k vám, ale aj pán Babela bol štátny tajomník, hoci teda bol odborný nominant, ale tak je to trošku politika, tak zabrdnem do toho. Aj z tých dát, čo pán Babela vlastne ukázal, to vyzerá na úplne jasný vzorec. Investujme do prevencie, vráti sa nám to 3000 krát. Prečo sa to nedeje?
Nedieje sa to preto, lebo my nie sme schopní sa učiť od tých lepších a nie sme schopní robiť politiky odvíjajúce sa od dát. Data-driven policies. My na Slovensku nemáme kultúru toho, aby sme sa pozerali na dáta a od toho odvíjali proste nejaké vízie, ktoré sa tvoria na základe nejakej reality, ktorú poznáme. Napokon, veď pán Babela to povedal veľmi jasne, o čom sa my tu rozprávame. My dnes ani nevieme, koľko máme na Slovensku vlastne onkologických pacientov. Ja sa pýtam, ako je toto možné v 21. storočí, ako členská krajina Európskej únie, keď proste my čelíme obrovským výzvam, ktoré musíme zvládať spoločne, tak ako bolo veľmi dobre povedané. Akurát, že Slovensko stále vymýšľa koleso. Naši politici sa stále tvária, že vymýšľajú kolesa. Tie kolesa už boli vymyslené. Oni tam vonku sú a oni sú podporené dátami. A my dnes presne vieme, práve vďaka krajinám, ktoré sú oveľa ďalej a na ktoré sa môžeme pozerať ako na tie best practices, čo funguje a prečo to funguje a ako veľmi to funguje. A čo musíme urobiť preto, aby to fungovalo. Hej? A tu sa dostávame napríklad k tej prevencii. To je alfa omega proste krajín, kde to zdravotníctvo funguje na inej úrovni. Akurát, že v tých krajinách pochopili, že keď sa povie slovo prevencia, to sa netýka iba ministerstva zdravotníctva. To u nás na Slovensku máme obrovský rezortizmus. U nás, keď sa čokoľvek týka zdravia, automaticky sa to týka iba ministerstva zdravotníctva. To tak nemôže fungovať. Keď sa bavíme o prevencii, tak je v tom ministerstvo školstva. Pretože my tú prevenciu musíme dostať do škôl. Ja mám 6-ročného syna, s ktorým chodím nakupovať. Keď ideme nakupovať v Bruseli, tak môj syn, 6-ročný syn, sa pozerá na ten semafor tých potravín a keď kupujem C-čkovú potravínu, tak ma zastaví. Viete prečo? Pretože on to vie zo školy. Pretože jeho to tam, ako 6-ročného, tam je školská dochádzka od 4 rokov, jeho to tam od 4 rokov učia, že je dôležité, čo jeme, že je dôležité, ako zdravo sa stravujeme, že je dôležité nefajčiť a nepiť. Ja sa pýtam, prečo na Slovensku je pomaly pivo lacnejšie ako voda. Toto všetko, čo hovorí napríklad kolegyňa z Lígy proti rakovine, alebo Patrik, čo hovoril, veď to tie mimovládne organizácie robia napriek štátu, nie vďaka štátu. V Belgicku, kamkoľvek prídem, k akémukoľvek ambulantnému lekárovi, je tam veľká obrazovka a tam ja vidím, čo to znamená tá prevencia. Tam mi animovaným filmom, ktorý pochopí naozaj od 5-ročného až po 99-ročného, vysvetľujú, prečo je dôležité, aby ja som chodila na tie screeningy. A potom inak vyzerá to financovanie vlastne v tom zdravotníctve, pretože keď my dnes vynakladáme strašne veľa prostriedkov na tú ambulantnú, hej, na tú nemocničnú časť. To je dôsledok toho, že nevynakladáme dostatočný počet finančných prostriedkov do tej prevencie, pretože my by sme mohli oveľa skôr samozrejme tých ľudí zachraňovať. A ďalej, keď som hovorila o tom školstve, to sa netýka len školstva, to sa týka napríklad Ministerstva práce, sociálnych vecí a rodiny, pretože z tých onkologických pacientov, tí, čo prežijú, tak sú z nich invalidi, ktorí sú napríklad sociálne exkludovaní, pretože sa nedokážu stať súčasťou pracovného trhu. To znamená, my keď sa bavíme akože dnes o starostlivosti, o onkologického pacienta, tak my sa bavíme o niečom, čo je komplexné, akurát, že toto na Slovensku nikdy nezaznievalo. A poslednú vec, ktorú k tomu poviem, že viete, my máme na Slovensku veľa politikov, ale žiadnych lídrov. My nemáme vízie. My nevieme, akú krajinu chceme mať zo Slovenska o 10 rokov, o 30 rokov. My nemáme celospoločenskú dohodu, že akú spoločnosť chceme my vlastne budovať. A potom sa čudujeme, že nemáme kontinuitu. Kontinuitu v čom? Nám sa každý rok a pol mení minister zdravotníctva, hej? Zostávajú tam nejakí úradníci, ktorí sa proste snažia, ale oni sa môžu snažiť iba do tej miery, ako sú vyslyšaní. A problém toho, že máme veľa politikov a žiadnych lídrov, je okrem iného aj ten, že okrem toho, že nám chýba tá vízia, že naši politici sú populisti. Oni vám budú hovoriť iba to, čo chce ten pacient počuť. Ale my sme tu nemali politika, napríklad ministra zdravotníctva, alebo teda opravte ma, možno vy si viacerí pamätáte viacerých ministrov zdravotníctva, možno medzi nami taký bol, možno Rudo Zajac to bol, ale my potrebujeme človeka, ktorý príde a začne kultivovať tú spoločnosť okrem iného aj v tom, že každý jednotlivec je zodpovedný za svoje vlastné zdravie. Toto je niečo, čo na Slovensku sa nenosí. My nie sme zodpovední za svoje vlastné zdravie do momentu, kým sa nám niečo nestane. A potom je už žiaľ častokrát neskoro. Toto isté mi chýba napríklad v sociálnych službách. My neučíme ľudí, že každý je zodpovedný za svoje vlastné starnutie, za to, akým spôsobom starne a ako zostarne, či dokáže byť aktívny do vysokého veku, alebo či jednoducho končí ako odkázaný na sociálnu starostlivosť. A ešte úplne posledná vec, že veľmi táto téma sa prelína s tou sociálnou agendou, pretože my sme jedna z posledných krajín Európskej únie, ak nie úplne posledná, ktorej chýba zákon o dlhodobej starostlivosti. Ani toto sme neboli schopní vlastne priniesť. Sú krajiny, ktoré to majú 30 rokov, viac rokov a tí ľudia sú potom zvyknutí na to, že si odkladajú peniaze na dlhodobú starostlivosť od svojej prvej výplaty. A to je tá zodpovednosť tých jednotlivcov, hej? A potom by sme sa mohli baviť o tom, že dokedy má byť ten náš systém takýto solidárny. Prečo máme byť solidárni za niekoho, kto je obézny, fajčí a pije, hej? Prečo štát nereguluje napríklad zvýšenými daňami na tieto nezdravé veci ako tabak a alkohol, proste celú tú politiku, aby potom vám uľahčili tú situáciu, keď idete do terénu, pretože vy nemáte čo v tomto suplovať ten štát a učiť ľudí, ako zdravo žiť.
Pani Kováčová, niečo ste chceli dodať?
Ťažko sa to počúvalo, ale je to fakt. Dodať len toľko, pred pol rokom sme boli na ministerstve školstva, kde sme opätovne zdôrazňovali tu aj s Patrikom, že je potrebné zaviesť výchovu k zdraviu, keď to nenazveme onkologická výchova, do učebných osnov. Tá reakcia bola veľmi vlážna, takmer nulová, takmer nepočuteľná. A hovoríme o tom na základe predošlých dlhoročných skúseností, aj aktuálnych skúseností, kedy naozaj obe organizácie do škôl chodíme, rozprávame s mladými ľuďmi. 50-tníkov a starších ľudí ťažko učiť prevencii, ale tú mladú generáciu musíme podchytiť a my z tých dlhoročných skúseností, aj aktuálnych, máme spätné väzby, že tí mladí ľudia sa zaujímajú, dá sa s nimi hovoriť, dajú sa učiť. Tak ako sa učia všetko ostatné, vedia sa naučiť aj toto. K onkologickým pacientom bolo spomenuté, čo s nimi, keď skončia liečbu. Pripravujeme, tak ako kolegyňa hovorila, že sa treba spájať, počúvať, pomáhať si, tak tiež sme v rôznych medzinárodných organizáciách a prekladáme do slovenčiny mnoho materiálov, ako sa vrátiť do zamestnania, materiály pre zamestnancov, ako komunikovať, ako sa chovať onkologickému pacientovi, aké má nároky a práva onkologický pacient ako zamestnanec. Jednoducho naozaj v rámci Slovenska sa týmto veciam nikto nevenuje. Skončím liečbu, momentálne máme aj veľa takých dotazov. Skončil som liečbu, som 5 rokov po onkologickej diagnóze, vylúčili ma z dispenzára v niektorom z ústavov. Chcem sa vrátiť ambulantnému onkologovi. Nie je to možné, nepríjme vás, lebo nemá kapacity. Napriek tomu počúvame, že tu stúpajú veľmi náklady. Takže toto sú bazálne problémy, s ktorými sa boríme a tak k tomu ako pacientské organizácie pristupujeme tak, že počúvame ľudí. Vzadu som vyložila žele na ukážku letáky, ktoré robíme pre ľudí. Kedy, v akom veku ísť na akú preventívnu prehliadku pre onkologického pacienta, čo mu môžeme poskytnúť, v čom mu môžeme poradiť. Jednoducho robíme to, čo vnímame z praxe. Nevymýšľame to koleso, ktoré tu bolo spomínané, ale počúvame a učíme sa od múdrejších a aplikujeme to v praxi.
Pán Babela, padlo tu teda, že ani len nevieme, koľko onkologických pacientov máme. Čo nám bráni v tom, aby sme takéto číslo mali? Kde je ten problém?
No, problém je na NCZD niekde. Hej. Čiže v podstate do NCZD tečú všetky údaje zo zdravotných poisťovní. Čo nám samozrejme chýba je dotiahnutý Národný onkologický register, kde donedávna sme mali údaje za rok 2012, teraz sa to posunulo na 2013-2014, že sa to hodnotí, teda finalizuje. Dotiahnuté sú dáta do 2021, ale tie nie sú zverifikované, čiže tie nevieme, či sú presné. Čiže principiálne...
No ale vysvetlíme si to. Ako je to možné?
A to sa pýtate vy mňa? Tak
ja chcem vedieť, že kde je ten problém, ako keby, že...
No ja vám poviem svoju skúsenosť. Ja v podstate som jeden z mála, ktorý mal teda možnosť na základe veci, ktoré mal rád a ktoré posudzoval a skúmal a dotiahnuť tie veci teda dokonca napríklad v tej liekovej politike. A keď som teda riešil napríklad cievne mozgové príhody, tak som získal dáta od NCZD, ktoré dostáva dáta, všetky dáta zo zdravotných poisťovní. A verifikoval som si to dátami priamo z poisťovní. A prišiel som na to, že ročný rozdiel nákladov medzi tým, čo mi dali poisťovne a tým, čo mi dalo NCZD, hej, tak bolo okolo 70 miliónov eur. Hej. Čiže čo sa s tými dátami v NCZD deje?
Tam ich niekto dopisuje ešte nejako, alebo dokresluje?
Odpisuje nuly, dopisuje, takto ja samozrejme nechcem nikoho nejakým spôsobom ani uraziť, ani povedať, že niekto si nerobí poriadne svoju robotu. A na druhej strane je evidentné, že máme tam niekde problém, ktorý skutočne potrebujeme vyriešiť. Hej. Potom sa dostávame do nejakej tej politickej roviny, lebo správne ste povedala, že som si teda vyskúšal tú pozíciu na tom ministerstve zdravotníctva a vnímal som priamo, ako funguje NCZD. Hej, ale to netreba to nejakým spôsobom asi rozvíjať.
Tak tam sa tiež vymenilo asi 5 riaditeľov.
Asi 5 riaditeľov. No. Problém je, že momentálne...
Za 3 roky, poviem na záznam. Hej.
Ináč štátnych tajomníkov sa myslím viac mení. Ako, ne? Ale v pohode. Ten systém, ako je momentálne vedené NCZD, je neudržateľný a nie je dobrý. Keď to porovnáme len s úzišom v Čechách, tak NCZD má 400 ľudí, český úziš má 150. Český úziš v podstate dáva v reálnom čase predikcie onkologických ochorení každej okresnej nemocnici, ktorá v podstate má onkologických pacientov na to, aby si vedeli plánovať zdravotnú starostlivosť. Hej? Keď sme v podstate upozornili NCZD na to, že toto úziš robí a že úziš je ochotný nám poslať ITčkárov, ktorí to naprogramujú pre podmienky Slovenska, tak sa nič nestalo. Hej. Čiže principiálne, tak ako pani poslankyňa veľmi dobre povedala, a všetci to vieme, jednoducho potrebujeme tie dáta skvalitniť, potrebujeme ich vyťahnuť, potrebujeme ich správne analyzovať, ale dáta musia analyzovať ľudia, ktorí rozumejú, o čom to je. Hej? Čiže to nemôže byť študent skončený po vysokej škole, ktorý v podstate nič nevie o zdravotníctve.
Ten kontext je dôležitý.
Presne tak. Čiže ja keď chcem dáta, tak ja presne viem, aké dáta chcem. A viem, že ktoré potrebujem. Hej? Čiže tam sa jedná o to, že my nepotrebujeme 400 ľudí, my možno, že potrebujeme 100 ľudí, ktorí naozaj tomu rozumejú a ktoré vedia v podstate tie dáta spracovať takým spôsobom, aby boli použiteľné pre nastavenie zdravotnej, liekovej, akejkoľvek politiky do budúcna. Vôbec nich sa nepohneme. A poslednú vec, ak môžem, asi 50% poskytovateľov zdravotnej starostlivosti nie je pripojených na e-health. Tak sa pýtam, aké vôbec dáta máme z e-healthu. Hej? Čiže to je ďalšia vec, ktorá jednoducho je taká, ktorú treba v podstate skutočne urgentne riešiť.
Penila? You wanted to add something?
Yes,
just the microphone. Yeah.
I think it's crucial to really have registries, both to follow, of course, the number of treatments and what kind of treatments, and also to follow up the patients. I mean, we heard about the cancer survivors, and I understand we do not listen here to François Meunier, but I mean, she is really pushing for this movement of the right to be forgotten. And since the cancer has really changed through the years, we need to see it with new eyes, that with functional treatments, we also have people who have chronic cancer. I mean, they are in a way cured, but they still need some attention and some treatments or follow-ups in healthcare. And that means that we have a number of people also that need certain efforts really coming from the whole society. It's not only the healthcare system, it's also about health insurance, it's about the access to labor market and the bank loans or whatever. So it's really something that really include the whole society, I think. But the registries is also something that should be in every national plan, you know, and every national cancer plan that is in line, aligned with the Europe Speeding Cancer Plan. So if you don't have a national cancer plan, we can see that within the Cancer Mission Board, that the countries who really have been working for a while with their own national plans and can follow up the goals in there. You can also see, you know, bigger efforts made by the different actors in common. And I also would like to say that we have no representative right here, I think, from the life science industry. But I think they also are a big and very important actor to provide with clinical trials and so on, also for new treatments. And if we don't have that in our own country, we need to have it in a broader view in the whole union, to see that we can have access to treatments in every country in the union. So it's something that should be in a national plan as well. So I think it's really important to see all these kind of actions included.
Myslím si, že Patrik chce dodať, že my nemáme ani základné lieky, ktoré sú inde však.
Presne sa o tom rozprávame práve s Evičkou, ani tie základné niektoré veci. A môžeme len naozaj že závidieť. Ja by som, keď môžem, možno aj trošku na odľahčenie situácie, ale zároveň niečo veľmi praktické. Hej, všetko so všetkým súvisí. To, že jeme, čo jeme, zdravý životný štýl, ktorý nám nič nehovorí, to je vec, ktorú si budeme musieť ako národ ešte nejakým spôsobom prejsť, a to je možno otázka 2-3 generácií. Hovorili sme o tom, že mladí sú schopní načúvať, ale kým sa dostaneme všetci do toho, že budeme aj rozlišovať, pozerať nejaký semafor a tak ďalej, to znamená, že ešte nejaké obdobie musíme prežiť. Otázka teraz, dobre, vychádzam zo skúsenosti môjho otca. Áno, mal by jesť brokolicu a ja neviem čo, niečo zdravé, špenát. No, tak môjho otca, keby som mu zakázal slaninu alebo klobásu, tak už nie som jeho syn. A toto je tak možno by som povedal koľko, polovica a možno 3/4 národa, že ťažko im zmeníme tie strávovacie návyky. Jednoducho to chce nejaký proces, to chce nejaké uvedomenie národa. Ale čo môžeme spraviť preto, aby neochorel a nezomrel? No tak práve tá účasť na tých preventívnych prehliadkach, nejako ho tam dokopať. A mne tu vždy, prepáčte, to vždy tak často hovorím, aj taký môj sen, tuto na prvom poschodí je moja stomatologička. A chodím tam každý rok, lebo systém v Slovenskej republike ma prinútil chodiť každý rok na preventívnu stomatologickú prehliadku. Lebo ak ju neabsolvujem, všetky ďalšie akékoľvek zákroky, ďalší rok si platím zo svojho. Nepreplácam ich poisťovňa. A ja stále sa pýtam, a nikto mi na to nedal odpoveď, ako to, že tí stomatológovia si to pred nejakými 15-20 rokmi vylobovali a o čo je bolavý zub horší, lepší, vážnejší, menej vážny oproti rakovine, ktorá vás zabije. Koľko ľudí zomrelo na bolavý zub? To by sme mohli mať aj štatistiku, nie? To vlastne nebudeme rátať nejako v stovkách. A koľko ľudí zomrelo na onkologické ochorenia? Pritom také jednoduché. A je to opäť koleso, o ktorých sme tu rozprávali. Jednoducho tie kolesá sú aj v Európe vymyslené. Nie každé koleso bude na to naše auto pasovať. My si nájdeme, čo k nám pasuje. Keď my sme napríklad neuvedomili práve v tých otázke prevencii a starostlivosti o svoje zdravie, tak ten národ nejakým spôsobom musíme jednoducho dotiahnuť na tie preventívky. Možno by sme mohli kopírovať, myslím, že Fínsko tí dosiahli veľmi rýchly pokrok práve v prevencii rakoviny prsníkov. Jednoducho donútili takýmto spôsobom, podobne ako my na tú stomatologickú prehliadku, ich na tú preventívku. A nemusíme byť nejaký reštrikční a nemusíme byť v tom negatívnom. Na Slovákov platia prachy. Tak nemusíme síce ich strašiť, že keď sa nezúčastníte týchto onkologických prehliadok, tak si budete platiť onkologickú liečbu. To by nebolo ani politicky podľa mňa priechodné, ale môžeme ich motivovať. Budete možno platiť do zdravotného poisťovňa menej ako tí ostatní. Že v podstate máme možnosť nejaké kolesá si namontovať na to svoje auto, aby to nejakým spôsobom fungovalo, a nerobíme to. Takže môj sen je, aby sme napríklad na Slovensku, lebo zjavne to tak nebude dlho fungovať, no tak nech sú aj prehliadky preventívne v onkologických ochoreniach, v tých, ktoré sú ľahko nejakým spôsobom rozpoznateľné, máme na to a tak ďalej. Vieme, že to je jednoraz, a hľadám na otázku, prepáč teraz tak moderátorsky, že a zase mi nikto nevie odpovedať, a prečo to nejde, keď to ide aj v iných krajinách? Čo, lebo poisťovňam by nárazovo na začiatku vyskočili obrovské čísla, pretože áno, samozrejme ten prvotný nástrel do tej prevencie bude chcieť obrovské peniaze, ale vráti sa nám to o 13, o 15 rokov. Hovorilo sa, že rakovina hrubého čreva, ak by sme naozaj tie 3 milióny Slovákov pravidelne každé 2 roky otestovali, tak návratnosť vložených investícií bolo 13,5 roka. To bol údaj spred 4 rokov. Je 13,5 roka. Čo terajší manažment nechce, akože aby ten riaditeľ, ja budem mať zlé čísla, ten riaditeľ o 13 rokov nechce mu robiť dobre. Nikto mi nevie odpovedať na tieto otázky, pritom sú vymyslené odpovede. Vieme načúvať, vieme sa učiť, vieme, čo by sme mohli urobiť a stále to nejakým spôsobom neurobíme. Mne je toto neskutočným spôsobom ľúto.
Pani Nikolsonová chcela niečo dodať?
Áno, to sa netýka len tejto oblasti, o ktorej sa rozprávame, ale to je taký slovenský národný zvyk, že vlastne nedá sa, u nás sa nič nedá. Akože každé rokovanie na akúkoľvek tému, keď prídem, tak vlastne 5 hodín strávime tým, ako mi vysvetľujú všetci, že ale u nás sa toto nedá. Všade sa to dá, ale u nás sa to nedá. Namiesto toho, aby sme sa že na pol hodinu zamysleli a povedali si, že ako by sa to možno dalo, že my potrebujeme naozaj že zmenu mindsetu z nejakého dôvodu, proste v tomto máme podľa mňa problém, v tomto nastavení. A potom ďalšia vec, že tá Európska únia, akože krása toho členstva v tej Európskej únii, samozrejme okrem eurofondov, ktoré nedokážeme čerpať, je aj v tom, že my tam máme naozaj tie best practices. To znamená, my môžeme sa učiť od tých lepších. To je vec, ktorú žiaľ Bohu Slovensko nevyužíva a myslím si, že je to zase len otázka toho mindsetu. My ako keby sme mali nejaké komplexy v sebe. My nedokážeme priznať, že my to nevieme. Ja som chvíľu mala občianske združenie, niekoľko rokov, asi 3 roky alebo 4, občianske združenie, ktoré sa volalo, že Dajme radu. Bolo to vlastne fokusované na deti z rare disease, akože so nejakými ojedinelými, zriedkavými ochoreniami. No nakoniec sme skončili naozaj pri tých onkopacientoch malých a my sme ich vlastne chceli akože linkovať s lekármi zo zahraničia, väčšinou teda v rámci Európskej únie, aby mohli získať second opinion. Keď tu na Slovensku už lekár proste zlomí palicu. Viete, aké to bolo strašne ťažké? My sme nakoniec aj zrušili to občianske združenie práve kvôli tomu, že naši lekári neboli ochotní zdvihnúť telefón a zavolať tomu lekárovi napríklad, ja neviem, vo Fínsku alebo v Dánsku, ktorého sme zohnali, hej, ako špecialistu na to špecifické ochorenie a na ten stav, v ktorom sa to dieťa nachádzalo, aby s ním odkomunikoval tú liečbu toho malého pacienta. Akože stretávali sme sa s hroznými príbehmi, ktoré ani nebudem radšej rozprávať, ale cítila som za všetkým takéto, že nie. Proste a nie, ja to neurobím. Niekedy to bola jazyková bariéra možno, ale v drvivej väčšine prípadov to bolo niečo, čo bolo proste v tom odborníkovi, ktorý nedokázal priznať, že už nevie ako ďalej a zavolať niekomu, kto je skúsenejší a požiadať ho napríklad o radu. A ja si myslím, že toto nám bude spôsobovať veľké problémy, lebo my, ak si predstavujeme tú Európsku úniu ako škôlku, kde nás chytia za ruku a budú nás samostatne akože prevádzať, hej, tými poschodiami, ktoré nám oni ako keby ponúkajú, tak to sme na veľkom omyle. To sa týka napríklad aj Beating Cancer Plan, kde sú fantastické veci, fantastické odporúčania, ale sú to odporúčania a je na nás, či ich budeme aplikovať, alebo či ich aplikovať nebudeme. Iná vec sú už samozrejme nariadenia smernice. Ja teraz pracujem na nariadení, ktoré sa volá, vytvára sa vlastne Európska databáza zdravotných informácií. To je obrovská vec, ale tam sa budú vkladať zdigitalizované dáta. A ja som tam tieňová spravodajkyňa, môžem vám povedať, že ja sa hanbím, pretože ja ten proces vlastne brzdím, pretože ja prichádzam z krajiny, kde my nemáme ani tretinu z toho, čo je bežné dnes v iných štátoch Európskej únie, ktoré chcú byť oveľa ambicioznejšie. A ja si proste netrúfam, akože my, tieto krajiny ako Slovensko, Rumunsko povedzme, hej, v niektorých hrebičkoch Chorvátsko je za nami, ako my celý ten proces tohto ambiciózneho nariadenia vlastne brzdíme, pretože my na to vôbec nie sme pripravení. A brzdíme krajiny ako Fínsko, Francúzsko, Belgicko, ktoré majú zdigitalizované dáta a sú akože ďaleko pred nami, čo v prvom rade akože umožňuje lepšie pre toho pacienta, ktorý sa ani nemusí stať v istom momente pacientom, hej, keď je dobrý prenos tých dát, čo u nás žiaľ Bohu, ako hovoríte, a to je teda tragédia, keď to človek počúva po toľkých rokoch, že sa s tým ako nevieme vysporiadať.
Pani Kováčová,
aby sme sa držali tej témy, ako zlepšiť život onkologického pacienta a odstrániť bremeno rakoviny, tak ja by som len skúsila krátko z praxe popísať cestu slovenského onkologického pacienta. Berme ideálny prípad, že je to priemerný človek, ktorý príde, priemerný v zmysle sociálneho postavenia, ktorý príde zodpovedne na preventívnu prehliadku a niečo mu objavia. V tom okamihu ho odporúčia, že potrebuje onkologické vyšetrenie a hneď mu odporúčia, teda dosť vo väčšine prípadov, nájdite si onkologa. Problém prvý. Častokrát nám človek zavolá, prosím, mohli by ste mi pomôcť nájsť onkologa. Nájdeme onkologa, urobí sa diagnostika a v tom okamihu sa mu povie operácia o 3, 4, 5 mesiacov Nehovorím bludy, sú to fakty. Žena s rakovinou prsníka diagnostikovaná v novembri, operácia v marci. Vďaka tomu, že sa k nám ozvala operáciu, mala v decembri, prsník bol odstránený. Keby bola čakala do marca, už tu dnes asi nie je. Dajme tomu, že prebehne operácia, keď sa podarí, že mu ju vybavíme skoro tomu pacientovi. Následne prejde cestu liečbou, nehovoríme o všetkom súvisiace veci s chemoterapiou a podobne. Ak je ten nešťastník taký, že potrebuje lieky, ktoré sú na výnimku, alebo ktoré už aj tu vďaka našim iniciatívam všetkých tu, čo sme, sú v kategorizačnom procese, aj tak nie je isté, že ich dostane. Na výnimku absolútne nie, na prvýkrát sú odmietnuté, čiže mu pomôžeme výnimku riešiť na odvolanie. Včera sme sa bavili s lekármi, našimi onkológmi na správnej rade o tom, neviem, či dobre poviem, pán doktor Bystrický ma opraví, neoadjuvantná liečba, to je, dobre vravím, zmenšenie nádoru, na ktorú žena potrebovala 3 000 každé 3 týždne. Lekár jej odporučil, neschvália vám to, zaplate si to aspoň 5 cyklov, čo je zhruba 30 000, aby sa vám nádor zmenšil, aby ste mohli ísť na operáciu. To sú fakty. Dobre, absolvuje liečbu, nebodaj dostane aj tie lieky, ktoré potrebuje, alebo nemá to šťastie a dostane sa do terminálneho štádia a sme v oblasti komunikácie o hospicovej alebo paliatívnej starostlivosti, ktorá je u nás na veľmi, veľmi biednej úrovni. Chýbajú nám hospice, o paliatívnych oddeleniach ani nehovorím. Dajme tomu, že je teda ten šťastnejší a vylieči sa, chce sa vrátiť do práce, počas celého štádia liečby sa dostane do ťažkej sociálnej situácie, čiže to je otázka toho, nevie, čo si má žiadať, nevie, na čo má nárok, nevie, k tomu pomôže, kto ho odporúči, čo si má nárokovať v sociálnej poisťovni. Nebodaj sa mu to podarí, chce sa vrátiť do zamestnania, sú osvetoví zamestnávateľia, chápaví, ktorí ho príjmu, ale sú takí, ktorí sa ho chcú zbaviť. Opäť nevie, že na to nemajú právo, niekto mu musí poradiť. Takže toto je asi zmap. A ešte jedna vec, po prepustení, teda po tých 5 rokoch, nevie si nájsť, ale to som spomínala, ambulantného onkologa, u ktorom bude v ďalšom sledovaní, lebo onkologický pacient po liečbe má veľa dôsledkov, ktoré súvisia s prebehnúšou liečbou.
No, na Slovensku má veľa ľudí rakovinu. Nepoznám nikoho, kto by nemal v rodine niekoho, kto má rakovinu. Patrik, tak prečo to nie je téma number one? Ja tomu nerozumiem, pretože občania chodia k voľbám a vyberajú si politikov podľa toho, čo cítia ako akutnú potrebu. A ja mám pocit, že toto cíti každá rodina ako akutnú potrebu. Čiže kde je v tomto procese celý ten problém? Čo, voliči na to zabudnú, je im to jedno? Čakajú nás voľby teraz.
No, to by som aj ja rád vedel, lebo my, tak ako tento národ, tak vždy sme viacerí prekvapení vždy z výsledkov volieb a potom vždy, ako to nejakým spôsobom dopadne. A toto naozaj tiež nechápem, lebo správne si to pomenovala, dnes už nie je rodiny, kde niekto nemá kontakt s onkologickým ochorením. A prečo je to tak? Jednoducho vždy asi prioritou je zrazu niečo iné, že v podstate ono sa to v tej chvíli dotýka nejakého istého percenta ľudí v danom momente, ale v podstate potom ten zvyšok, tá väčšina v podstate nejakým spôsobom sa cíti byť ohrozená niečím iným, než len napríklad nejakým ochorením.
Utečencami, hej?
Napríklad. Vždy to niečo preruší. A potom samozrejme tie populistické elity, ktoré teda naozaj hrabú tie hlasy na úplne iných témach a zdá sa, že to jednoducho prehluší. Inak je úplne tragické, keď som aj teraz počúval, to je, že vlastne môžeme skonštatovať, že na Slovensku sa nedokážeme postarať o pacienta onkologického s dobrou prognózou, ktorý v prípade včasnej diagnostiky a rýchleho zásahu nastavenia liečby, okamžitej dostupnosti potrebnej liečby a podobné veci, aj teda finančne alebo fyzicky vôbec mu nejakým spôsobom doručiť. A my sa nevieme vlastne postarať ani o tých, kde v tom predchádzajúcom vlastne zlyháme. Ani o tých v tej hospicovej paliatívnej starostlivosti. Čiže aj tam, kde tam ten systém úplne zlyhá, my sa nevieme postarať ani o tých, ktorí nám už sa dostanú vďaka tomu nášmu zlyhaniu do terminálneho štádia a nevieme sa o nich postarať. Ak máme to šťastie, lebo to bola aj téma vlastne dnešnej konferencie, ich potom nejakým spôsobom inkludovania do toho ďalšieho života, kam sa vlastne môžu nejakým spôsobom vrátiť, kto ich supportuje, kto nejakým spôsobom ich chráni. Bavíme sa o tom a môžeme sa dlho baviť o tom, ako sú akceptovaní, aké majú možnosti na tom trhu práce, ktorý je dnes naozaj divoký a proste jednoducho vyžaduje celého toho človeka a zrazu títo ľudia sú vlastne handicapovaní oproti tým ostatným. Nedokážu v podstate v tej istej miere zastúpiť plnohodnotne a niektorí napríklad aj veľmi chcú. Pre niektorých je to možno riziko. Čo keď sa mu to ochorenie vráti? Ja takého rizikového človeka nepotrebujem, ktorý zas o chvíľku a odíde mi niekam na penku alebo niečo sa udeje a zase jednoducho nebudem mať. To sú už ale otázky zase možno také morálky, etiky, ľudskosti a aj v tomto podľa mňa Slováci máme tak trošku asi medzeru, že?
Nech sa páči, pán Babala. Neviem, či sme s týmto panelom nemali najprv začať, aby sme v tejto depresii začali a skončili niekde pozitívnejšie, ale už to nezvrátime do toho. Pozitívnejší, áno.
No
Na budúce to otočíme. Nech sa páči.
No, ja som práve na to chcel reagovať, lebo toto je ako všetko zlé, čo hovoríte. Ja si myslím, že tá situácia, ja som si vedomý, že vy sa stretávate skutočne s prípadmi, ktoré sú veľmi ťažké, treba ich riešiť. Ja poviem ale druhú stránku veci. To isté ja žijem s vami roky a poznáme sa fakt, že už nejaký ten rok a tie analýzy, toto nie je moja prvá. A môžem súhlasiť s vami, že skutočne sme doplatili na veľmi zlý zákon za posledných 10 rokov až tak, že pacienti musia predávať, musia žobrať s prepáčením. Na druhej strane musíte obidvaja povedať, že 22 a 23 bol prelom. Čiže máme tu 22 onkologických liekov zaradených v roku 22, vyše 30 indikácií a ten trend pokračuje aj v 23. Veľmi dobre, akože za posledných 10 rokov sa to fakt, že nedá porovnať. Máme takmer všetky lieky na plúca už zaradené, tie, ktoré ste chceli a myslím, že 80 alebo takmer 90% liekov na karcinom prsníka, ktoré potrebujeme. Čiže skutočne sa posúvame milovými krokmi dopredu. Áno, máte pravdu. Z 12 000 výnimiek, ktoré dostáva Všeobecká každý rok, 1200 sa neschváli. A medzi tých 1200 všetci tí ľudia jednoducho idú za vami, prosia o pomoc. Áno, to sú tí ľudia, ktorí nedostanú. Preto ten výnikový režim treba redukovať, treba ho pretransformovať, čo najviac liekov dostať do kategorizácie, na čo budeme potrebovať, keď sa toto nezastaví, asi 3 až 4 roky maximálne a jednoducho urobiť z výnikového režimu inovačný fond, ktorý bude slúžiť na to, aby sme tak ako v Nemecku dostali inováciu do systému za 40 dní, nie za 550, ako je to teraz. Ale to je všetko, to sa dá spraviť a dá sa to spraviť veľmi rýchlo. A toto sú tie dobré správy, čo som povedal. Čiže nie je všetko zlé.
Ďakujem, že ste intervenovali, už som tu chytala depresiu.
Ja som zvyknutý, lebo oni stále veľmi dobre lobujú za tých pacientov, ja si to vážim, lebo toto tu, čo vidíte, zástupcov teda pacientov, týchto dvoch, sú skutočne, to je zmena od spodu. Aj vzdelávanie v školách, chodili po mestách, po školách, jednoducho niečo úžasné. To by mal fakt, že podporovať a financovať štát, robiť to. Čiže oni sú fakt ľudia,
prvej
ktorí...
línii.
Presne tak. Čiže my sme sa snažili aj po tom, čo sme spolupracovali o to, aby tie lieky boli čo najdostupnejšie a ten systém je na to pripravený. Len tá kontinuita sa musí skutočne zachovať a to nevieme, že čo sa stane po 30. septembri. Takže, ale nastavené to je, ten čas to ešte samozrejme potrvá, ale principiálne ja pevne verím, že nie je všetko zlé.
Držme si palce. Penila, you wanted to follow up on something.
Yes, I think I said to someone during the lunch break that, well, of course, we need to address the things that are not working, of course. But sometimes we also need to pick the cherries out of the cake and see also what is working. And we just heard an example here about accessibility to drugs or new drugs and so on. And I think that, and I repeat myself here, but to really take advantage of the membership in the European Union and to see what kind of help you can get. We heard it from Simon before about new technique and how to get some help for that kind of increasing of knowledge and resources, of course, for Slovakia. But also I would like to address the fact that, because you mentioned also the media, and to make use of the media and to really also, of course, address what's not working and to increase the knowledge. But to increase the knowledge is also to take some good examples. I mean, I'm a cancer survivor myself, 2.5 times, because the half time was really preventive care. So I didn't have to go through treatment. And between my 2 cancer periods, I also had a heart transplant. So I know how it is to be a patient. And I don't think you need to have that kind of experience yourself for anything in politics or anywhere. But I do think it helps when you would like to make some change. So I think really to make change, also to take advantage of the people that can really, talk about their stories and talk about both the difficulties but also how it has helped the person. And I can say that it has helped me also to, of course, in my mission now at the EU level, to understand the need for both treatments and for diagnostics and all these kind of goals that are set. But that also triggers me, at least, and I hope it triggers you as well, what kind of position you have, that really try to make all these efforts worthwhile when you see people who are really actually surviving cancer, and to get a new life, and to get the opportunity also to go out in the labor market again, or be able to go back to your work, and to be an ordinary person in somehow, to have some kind of ordinary life. I think that is so very important, to also see the good things that is happening. So a balance always in this subject. Otherwise, we all get depressed, I think, in some way.
Hej, ja som veľmi rada, že ste do toho vniesli taký pozitivizmus, tak ja to dám zase naspäť. Lebo jednu vec, akože my sme že v centre Bratislavy, hej, proste palisády, a bavíme sa vlastne ako ste vypovedali, o tom priemernom pacientovi, ktorý má dostupnú tú zdravotnú starostlivosť, vie niekoho vyhľadať, vie dokonca, že má ísť na nejaký screening. Ale asi by sme v tej debate nemali zabúdať na tých, ktorí sú napríklad zo sociálne vylúčených spoločenstiev, napríklad z rómskych osád, hej, kde sa akože nedá rozprávať o tom, že majú tú knowledge, že majú tú vedomosť, že tam dosiahla nejaká osveta, hej. Ja chápem, že vy robíte, čo môžete proste v tých mestách, možno okresných, krajských, ale tam častokrát teda, nedávno som bola zase v osadách a to je proste čistá katastrofa, takže na tých najzraniteľnejších netreba zabúdať. A tu špecificky by som chcela poukázať aj napríklad na jednorodičov, pretože my máme veľmi veľa matiek, ktoré sa starajú samé o deti, alebo otcov, ktoré sa starajú samé o deti. A ja viem o zopár osudoch, kedy oni vynechávajú napríklad screeningové programy, pretože oni sa fakt boja, pretože nemajú takú dôveru v ten štát, že keby sa aj niečo stalo, čo bude s tými deťmi. A napríklad na túto špeciálnu zraniteľnú skupinu štát akože zabudol úplne, hej? Pretože keď sa objaví matka s 2 deťmi ako samoživiteľka, ktorá nikoho nemá a ešte jej nájdu rakovinu prsníka a musí cez to všetko prejsť a nemá chudera čo predávať, ona ani nemá nehnuteľnosť, ktorú by mohla predať. Poznám mnohé, ktoré takto zachránila rodina akože v zahraničí, že sa museli presťahovať do zahraničia, napríklad do Českej republiky, aby mali dostupnú tú inovatívnu liečbu, ktorá ich napokon zachránila, ale proste nemajú takéto možnosti všetci. Takže keď sa bavíme o tom, že ako sme pokročili, obávam sa, že tam na týchto miestach máme ešte stále také tmavé škvrny.
Máme. Pán Babele, niečo ste chceli ešte dodať? Pozitívne, hej.
Viete, Tolkien napísal v Pánovi prsteňov, že aj ten najmenší človek dokáže zmeniť kurz histórie. Hey, even the smallest person can change the course of the future. A ja si myslím, že každý by sme mali začať od seba. A teda ja nechcem povedať a nechcem sa chváliť, ale ja som fakt, že začal od seba. A keď som prišiel na ministerstvo zdravotníctva, tak som relatívne veľmi ako tak pri zemi som si uvedomil, že čo asi viem a čo neviem spraviť a čo neviem zmeniť. A druhú vec, čo som si uvedomil, že som v službe. Hej? Čiže ja som bol v službe asi 18 mesiacov, či 16, či 15, či koľko a počas tej služby sa nám skutočne podarilo jednu vec zmeniť. Ako fakt, že veľmi dobre. Hej? Čiže čo my potrebujeme je viac ľudí, ktorí to cítia ako svoju osobnú misiu a začali od seba, ako rodič, učiť deti, ako si správne umývať zuby, ako piť vodu namiesto Coca-Coly, ako sa správne stravovať. A ja, ako človek, ktorý je vychovaný slovenským školstvom a teraz má priestor vrácať späť a dostal sa na ministerstvo, tak vrátiť to tomu štátu tak, že sa mi, chvála Bohu, teda podarilo zmeniť zákon, ktorý bol úplne že zlý. Aby pacienti, ktorých sme stretli v Malackách na ulici, nám povedali naši známi, pár, ktorý je onkologicky chorý a ten jeden hovorí, že vieš čo, že konečne môj lekár nemusí žiadať ten liek na výnimku v poisťovni, že konečne si môžem ísť po ňoho do tej lekárne. Prepáčte, že pre mňa to je satisfakcia, ale bez takýchto ľudí nepohneme ten systém dopredu.
Tak, priestor na otázky z publika. If you have any question from the audience, please, now is your time.
Ďakujem. Ja nemám ani tak otázku, ako skôr na doplnenie, taký komentár. Ja by som veľmi rada povedala, že bolo tu hovorené, že možno neexistuje taký minister, ktorý by tú prevenciu mal ako prioritu, ale ja si myslím, že určitý kredit patrí bývalej ministerke Kalavskej, ktorá v podstate tú prevenciu začala veľmi prioritizovať a rok 2019 bol rok prevencie. V tom roku sa prijali akčné plány Národného onkologického programu a takisto aj bývalý štátny tajomník, pán profesor Špánik, ktorý v podstate je predseda screeningovej komisie stále na ministerstve zdravotníctva, tak by som chcela povedať, že ten kredit tam vnímam, za ich pôsobenia vlastne vznikol aj odbor verejného zdravia, screeningu a prevencie, ktoré funguje stále a zapájame sa do rôznych európskych projektov a iniciatív. K tomu rezortizmu by som povedala len toľko, že áno, súhlasím veľmi, ale ten rezortizmus je silný len do takej miery, do akej dovolia členovia vlády, aby rezortizmus bol. Čiže dúfam, že v budúcnosti toto bude pre nás výzva, ktorú zdoláme. Veľmi sa teším, že pani Nicholsonová je ďalšia šampiónka, okrem pána Baláža, práve v tejto téme boja proti rakovine a vítame ju teda, aby nám pomohla mnohé veci lepšie implementovať aj na Slovensku. Veľmi sa tešíme, že ste už len tou svojou prítomnosťou podporili túto tému, takisto ako pán Baláš. A chcela by som povedať aj k tým znevýhodneným skupinám. My na nich nezabúdame z toho systémového hľadiska. Možno na tej individuálnej úrovni sa stále nájdu príbehy, ktoré trhajú srdce, ale my spolupracujeme napríklad na projekte Európskom preskripte, ktorý sa zaoberá samotestovaním rakoviny krčka maternice práve u rómskych znevýhodnených dievčat a žien, s tým, že do budúcna chceme výsledky tohto výskumného projektu využiť práve na tvorbu zdravotnej politiky. Ďalším príkladom je projekt EU-River, ktorý sa zaoberá očkovaním proti HPV práve u rómskych komunít. Máme akčný plán zdravie v rámci rómskej stratégie, čiže myslím si, že tie aktivity a tie plány ministerstva zdravotníctva sú, len otázka je, že kto má tú zázračnú paličku na vyriešenie všetkých problémov sveta. Asi nikto, ale z pohľadu nášho, ktorý v tejto téme v podstate už od roku 2017 aktívne v rámci aj možností a financií Európskej komisie aktívne sa zapájame, vnímam toto stretnutie ako unikátne. A veľmi ďakujem všetkým prítomným, ktorí prišli, pretože toto je taká nádej do budúcna a zároveň mnohí z nás máme názory. Niektorí aj riešenia, lebo ich poznáme práve z tejto európskej úrovne, ale niektorí z nás v tejto miestnosti majú skutočnú silu niečo zmeniť. Takže dúfam, že sa to stane realitou. Ďakujem.
V každom prípade to sa vyrieši najmä tým, že nebudú žiť ľudia na Slovensku ako v stredoveku v niektorých komunitách. Asi bez toho sa nepohneme. Ešte nejaká otázka z publika, prosím? Nech sa páči.
Dobrý deň, Dominika Kormanová za občianske združenie Amazonky ženy s rakovinou prsníka. Ja by som sa chcela spýtať, bo táto debata bola dobrá, počuli sme veci, ktoré sme možno už počuli na iných debatách. Ja by som sa chcela spýtať, bolo spomenuté to, že chýbajú nám dáta. Už niekoľko konferencií už na niektorých konferenciách som sa zúčastnila a stále, keď padne téma to, že nám chýbajú dáta, tak mám pocit, že každý sa vyhovára na niekoho iného. Ja pracujem v súkromnej spoločnosti, kde robíme obrovské projekty a keď je akýkoľvek problém, tak sa sadne, nájde sa líder, ktorý zhrňa všetky body, ktoré sú dôležité, aby sa na ne nezabudlo. A ten problém sa rieši, hľadajú sa odpovede. Takže prečo je to tak, že vždy za to môže tá spoločnosť, tá poisťovňa, tí lekári, prečo tie dáta naozaj chýbajú, prečo sa to nedá vyriešiť? Možno, že asi na to nie je jednoduchá odpoveď, ale toto je niečo, čo je naozaj frustrujúce, keď to ako z toho pohľadu pacienta naozaj už niekoľko rokov počúvam. Ďakujem.
Nie, určite máte pravdu. Bohužiaľ, neviem to. Teda takto. Ja si myslím, že viem, ako by to malo fungovať, lebo som videl, jak to teraz funguje a jak to nefunguje. Principiálne, ale mal som podobnú frustráciu ako vy, keď som prvýkrát chcel v podstate získať nejaké dáta. Vtedy to bol mnohopočetným mailom. A podarilo sa mi do toho partnerstva zapojiť všetky relevantné organizácie, ktoré mi pomohli na koniec dňa. Ktoré tie dáta pre mňa našli a v podstate vedel som urobiť analýzu. Čiže podľa mňa, keď niekto veľmi chce a ide po tých dátach a je to hlavne človek možno, že z toho akademického, z toho medzipriestoru, kde tie organizácie sa necítia ako ohrozené, že čo s tými dátami idete robiť, tak v princípe tie dáta sa majú nájsť. Ale čo sme chceli urobiť a čo teda nás čo zastavili teda hneď po mojom odchode z ministerstva, bolo to, aby každý, kto chce študovať dáta, mal na ne nárok a aby boli dostupné v NCZI cez tzv. Dátový hub. A toto bolo v podstate pripravené už legislatívne v zákone 153, čo sa stade dalo preč. Teraz sa tam rieši len jedna či dve veci, ale toto je cesta. Čiže tak, ako nám hovoril pán profesor Pecov, ktorý tu bol nedávno hovoriť o pacientských registroch, hovoril nám, že všetky severské krajiny to majú cez 200 registrov, ktoré sa spájajú dokopy a každý má prístup k dátam, keď o ne požiada. A platí sa za to nie, že vy dostanete dáta, ale platí sa za to, že vám niekto spracuje, taká organizácia, ktorá má na to ten certifikát. Takže opäť, tá cesta tu je relatívne veľmi jednoduchá, ako to spraviť. Len v princípe my sme tak prísni, čo sa týka GDPR, že sme najprísnejší v Európe. Čiže nikto nechce nejakým spôsobom dávať dáta, lebo každý sa bojí, že identifikuje mňa ako Roba Babelu, že ja neviem, že som teraz v sledovaní každých 6 týždňov.
Ja by som k tomu dodala, že by pomohla profesionalizácia štátnej správy namiesto politických nominácií. Myslím, že to bol hlavný problém NCZI. Ale som vás doplnila.
Ale tá cesta tu je, ale je relatívne.
Hej. Pani Nikolsonová, veľmi krátko, lebo už musíme končiť.
Áno, ja som vás chcela potešiť, lebo vlastne hovorila som o tom nariadení, ktoré teraz príde na vytvorenie toho európskeho priestoru pre zdravotné informácie. To bude povinné. Nariadenie je niečo, čo my si musíme preklopiť proste do našej legislatívy. Ja vám teraz neviem povedať, že či to bude o 2 roky. Teraz je to v parlamente, je to v rade, ako ešte to nie je dokončený proces. Tam bude určite nejaké prestupné obdobie práve pre tie pomalé krajiny, ako je Slovensko, aby sa proste na to nejakým spôsobom pripravilo. Ale toto bude revolúcia, pretože prakticky vy ako pacient, každá jedna vaša informácia o vás, úplne, že každá jedna bude musieť byť zdigitalizovaná a uložená v tomto obrovskom úložisku. To je vlastne ten primárny cieľ, aby každý lekár, ktorý si klikne na vaše rodné číslo, proste sa mu tam vysype anonymizované informácie, ale všetky o vás. A druhý cieľ tohoto je, aby to išlo na vedecké účely. Tam to bude ale predpokladať informovaný súhlas toho pacienta. A tu ja vidím obrovské riziko pre tento náš región, ktorý je najviac postihnutý dezinformáciami, že aby sa vám zase nejaký pardon my French, idiot, nepostaral o to, že ľudia sa budú báť vkladať tieto informácie do tej databázy preto, aby to išlo na vedecké účely, čo môže zase znamenať akože revolúciu v oblasti vlastne tej inovatívnej modernej liečby. Hej. Takže toto je obrovská podľa mňa nádej pre nás. Keď už to neurobí žiadny minister ani po 30. septembri, tak to určite spôsobí to nariadenie Európskej únie.
Držme si palce, ďakujem vám veľmi pekne, že ste sa dnes pridali, ako to povedala pani Kaleva, do aliancie boja proti rakovine. Patrik Herman, ďakujem veľmi pekne, že ste tu boli. Eva Kováčová, Penila Ganter, Lucia Ďuriš-Nikolsonová a profesor Babela. Ďakujem vám veľmi pekne, že ste tu boli. Now, let's switch to English. In the end, let's wrap up the whole thing. Please welcome again Mike Morrissey, Andre Carvalho a Štefan Korec for final remarks, please. Thank you very much. Thank you. Andre, you're the first person here. Will you start?
Here I am again. Should I just start?
Yeah, please.
Okay.
The others will follow, hopefully.
Okay, yeah. So I would like to thank you very much, this opportunity and this to be here today, to thank the Onco Alliance for the invitation and to make us part of this event together with the European Commission, the European Cancer Organization, and the Parliamentarians for Actions, and the Minister of Health of the Slovakia Republic. I think this was a great event. As we commented before, our project is about cancer screening, but cancer screening doesn't work if you don't talk about the cancer continuum care, and if you don't make it multidisciplinary, if you don't bring all the stakeholders for the discussion. Otherwise, we'll not change what we want. Is decrease in incidence of cancer, improve survival, and decrease mortality. So I'd like to thank those that endure until the end of the day, and it was a pleasure to be here. Thank you so much.
Thank you very much.
Well, thank you. Thank you for not just for the invitation, but for everything we've shared and learned today. I think it's amazing not just how much interaction there's been with all of you from Slovakia and learning so much from all of you, but you've managed somehow, Stefan, to get people from Latvia here, Germany here, Sweden here. It's a real incredible gathering of experts, which has focused on national implementation. And I think when we talk about the cancer mission, when we talk about the Beating Cancer Plan, we must never forget the importance of prioritizing those questions around implementation. And I know there are people in this room who are working very hard on that. I think we shouldn't underestimate how hard it can be to implement plans, but I think some great ideas and some great sharing of experience today is the start of a journey. Looking forward to coming back when we've got a new health minister and a new government or a continued government. I don't want to get involved in the politics, but I'm looking forward to coming back in the autumn and having meetings on the next steps, because I think once the political situation in the country is clear, then I think we collectively have a lot to offer in terms of supporting Slovakia in its important next steps on cancer.
We will see if we look forward to the new minister. We don't know yet. Thank you very much. Štefan Korec.
Thank you very much. Thank you very much, Mike. Thank you very much, Andre. But most of all, thank you very much, everybody. Again, patient organizations, physicians, politicians, pharma companies. Yes, physicians. We have everybody here. We have all the stakeholders here. And I'd like to take several thoughts from Mike's talks and also Andres' talks. Number one, I'm looking forward to coming back. This should be, we are hoping that this is the first possible founding conference that will be repeating on a regular basis. The exchange is extremely important. We are learning. We are hoping to fix the mistakes. And yes, we are welcoming all the help and all the support what we can get from you. And again, yes, we are ready to implement as much as we can. And yes, we are hoping that this will be on a regular basis, and we'll see you here again in Bratislava. So thank you very much, everybody. Thank you for coming, and thank you for actively participating. Thank you.
Thank you all. Let's hope we get better quality care for Slovak cancer patients after this event. Thank you, Štefan Korec, for organizing this whole event, and thank you for all of you for participating.
I need to have one important remark. You said, thank you, Štefan Korec, for organizing. I want to thank all the organizers here who helped the whole team. It's not me. Again, we are amateurs in organizing this type of meetings. And for amateurs, I'd like to congratulate you, organizers, and thank you again.
Thank you. Have a nice evening.